nervous system pathology. So for peripheral nervous system, it is not a separate chapter. It is included in the soft tissue tumors, because most of them, they are tumors, but there are some diseases which are not tumors. But we shall see this in the musculoskeletal system or peripheral nervous system. So here we will concentrate on the brain and the spinal cord, which are the components of the central nervous system. So this is the content. So we'll start with developmental abnormalities or anomalies. Then we shall see the spinal cord lesions. We shall see meningitis, cerebrovascular disease, trauma, the demyelinating disorders, dementia, and the degenerative disorders. And then we'll end with the central nervous system tumors. So this is the list of books you should use. So the first one, I think you are familiar with it. It is the text in this presentation. Most of it comes from this book as usual, but there are some which I took from this book, the WHO classification of tumors of the central nervous system. So here there is a mistake. I doubled off. So it is the most recent book, which was published last year. Otherwise, the previous one was published in 2016, for which we have the hard copy. So we have also access to WHO books nowadays. We bought an access, so we are updated on this. So we start with the developmental anomalies of the central nervous system. So as you know, in embryology, you know that in embryology there is a time when there is organ induction, and then there is migration of the organs and so on. So, and if there is a mistake during the time of organ induction, there are diseases which will now be manifest. If the problem comes during the migration of cells and so on, also there are some specific diseases which will ensue, and so on. So the induction, it takes place during the period of 2.5 to 6 weeks of pregnancy or gestation. So if then there are problems during that time, there will be neurotube defects. And in such cases, a child can have different diseases, such as anencephaly, meaning there is no brain, spinal dystrophism, encephalocele, so there is a brain, but it is not inside the intracranial cavity, holoprosencephaly, and many others. So the migration takes place between 3 to 6 months. So here it is weeks, here now it is months. And here, if the problem happens at that time, the child can present with dyssencephaly, microcephaly, it means a very small brain and a very small head. The dyssencephaly, I think here there are no Chiari and the sclerosis, so the brain is just very smooth on the surface. So polymicrogyria, agenesis of the corpus callosum, and so on. So myelination, the problem with myelination can take place during from 2 months up to when someone is a young person. So synaptogenesis takes place at around 20 weeks of gestation up to adulthood. So someone can have a problem with synaptogenesis. For example, those having trisomy 21, or those thought to have a fragile X chromosome, and those with cretinism, remember we saw this in the thyroid pathology. So in general, area inserts cause more severe structural damage. And you will see that's why probably during the first trimester or term of the pregnancy, the woman, she must be very careful. So usually most of drugs used in medicine, they are not prescribed. because they can cause such problems, not only on the central nervous system, but also to other systems. So the first trimester of pregnancy is very sensitive, because if there is an insert at that time, there will be very severe consequences. So we shall then discuss a few of these diseases listed here. So we start with this one, spinal dystrophism. So dystrophic disorders, which here, so it is the one was selected among the problems which happen during organ induction. So here there will be a failure of neurotube folds to close during development. So you remember in embryology you have this neurotube folds here, and you see the summit and so on. So you see that here they are not fused, here they are fused, and here they are completely closed. So niyo mpamvu umuntu avuga hano ubu nk'ubwonko ubu burimo imbere mu mutwe, ndetse na spinal cord iri imbere aho igomba kuba muri vertebra, ariko hari abantu bavuka hano ubwonko cyangwa se igice cya spinal cord iri hanze. So this is due to the fact that the closure didn't take place. I think it is easy to understand. So prenatal testing may reveal an elevated maternal serum AFP. Folate deficiency is one of the problems. Ngira ngo muzamubona n'impamvu abadamu batwite babahari ibinini babaha supplements, harimo na folate cyangwa acide folique ndetse na fer cyangwa iron. Ko ibi byombi bigira uruhare rukomeye mu gutuma ubwonko bw'umwana buba well developed. So because you cannot know who has the folate deficiency or not, so they give it to everybody. Kubera ko anayigize ibaye nyinshi umubiri ntabwo uyabsorba, yafite ihagije, ariko yatayifite urayabsorba. So kuba umuntu ayisanganywe bakamwongera indi ntacyo mutwara. So neurotube defects range from small bony defects in the rambosacral region, nibyo bita spina bifida. Muzamubona ntabwo ari benshi, ariko hari igihe muzajya mubona umuntu avuke ubona ko igice cya moelle épinière cya spinal cord kiri inyuma, kibone ku mugongo. Hari abo bitagaragara neza, wenda kikaba kiri imbere mu ruhu, akitaje inyuma y'uruhu, nabyo birashoboka, ariko buzasanga kenshi afite ibintu by'ubwoya bwinshi aho ngaho kuri lumbosacral area, ukanga ni imisatsi. So others, they will have a craniorachisis, anuva umutwe urafunguye ubwawe inyuma, ubwonko buri hanze. So spinal bifida ni kuri spinal cord, craniorachisis ni hejuru ku mutwe. Another is the myelomeningocele cell, which occurs most commonly in the lumbosacral region in the spina bifida. So ahangaha myelomeningocele hari ubwo usanga haje meninges gusa arizo zasohotse hanze, ariko spinal cord yo yagonye imbere, ariko iyo biza hari ubwo binaza nabyo mention. So I think to distinguish spina bifida and the myelomeningocele, you will need the histology to confirm which is which. Otherwise, clinically they look the same. So these neurotube defects, they arise from incomplete closure of the neurotube, as I explained. So the neuroplate invaginates early in gestation to form the neurotube, which runs along the craniocaudal axis of the embryo. So kuva ku mutwe kugera kuri aho twakwita kuri coccyx. So the wall of the neurotube forms central nervous system tissue. The hollow lumen forms the ventricles and the spinal cord canal, and the neural crest forms the peripheral nervous system. So this is embryology, purely embryology. So this is associated with low folate levels prior to conception or to pregnancy. We mean these defects. They are there when someone has a low folate levels. And I was explaining why even the government of Rwanda is prescribing these folate supplements to every pregnant woman. So this is detected during prenatal care by elevated alpha-fetoprotein levels in the amniotic fluid or in the maternal or blood. Of course, in our context, ntabwo bikunze kuba ko dufata amniotic fluid umudamu agitwite kubera ko ibyo bisaba bishobora gutera consequence. Membrane can be ruptured. The amniotic fluid membranes and infection can go there. So that's why we don't do it usually. But you can measure this in the maternal blood. If AFP is increased, this can show that there is a problem. But AFP, remember, it is not specific here. We saw it that it is increasing in other conditions such as some tumors and embryonal tumors, as we saw last time. So you see here it is an encephalus, so you see where eyes should be, but there is no brain. So there is no brain. I think you can see it clearly. There is absence of the skull and the brain. This leads to a frog-like appearance of the fetus, as you see here, resulting in maternal polyhydramnios since fetal swallowing of amniotic fluid is impaired. Ntabwo narabisobanura ubushize yuko igihe umwana atanywa iriya amniotic fluid yogamo iba nyinshi nyine akagira polyhydramnios. Mu gihe agira amniotic fluid iba nke cyane igihe umwana adakora afite ibibazo muri urinary system. So because part of the amniotic fluid is just a urine from the fetus. So the spinal bifida, as I was explaining, is a failure of the posterior vertebral arch to close, resulting in vertebral defects, disruption of the caudal end of the neural tube. I think they are listed here. This diagram, I added it. It is not in that book I shared, so I took it from other published materials. So you see craniorascisis, you see this is, so the buttocks here, so the head should be here. So you see that everything is open from the brain, from the head up to the almost the sacrum. So everything is out, the brain, what we could call brain and spinal cord. So anencephaly, so there is no brain there, and also the skull bones are not there. Maybe here the spinal cord is there, but the brain is not there. Encephalocele, so part of the brain goes outside of the cranial cavity, and this is like a herniation of the meninges and the brain. So, but here the brain will be retained by the meninges, but you understand that nobody can survive with this. So surgery will be needed where possible. So in encephaly, so here occipital skull and the spine defects with extreme retroflexion of the head. So it is not very clear here. There are defects, but it is not as clear as in the other things. But here the nahumwana agira retroflexion of the head, umutwe ukajya inyuma cyane. Hari n'izindi turibone indwara umwana aba ameze gutya cyane cyane iyo muscles ze zidafata akabaraga ngo afata umutwe, kuko umwana umaze ibyumweru runaka aba agomba gufata umutwe, wamuterura umutwe akawegura ubwe utagomye kuwuterura. So spina bifida occulta, usually it is asymptomatic neurotube defects in which some of the vertebrae are not completely closed. So niho navugaga kenshi nta kintu n'inyuma ikintu gishobora kubikumenyesha nuko hari usanga hari inyuma harameze imisatsi myinshi kikaba ari nk'ikimenyetso. Otherwise there is no mass like here. So this is closed spinal dystrophism. It is closed because here there is a skin around it. So deficiency of at least 2 vertebral arches here covered with a lipoma. So the lipoma, this is you remember, a tumor rising from the adipocytes. The niyo ihari, otherwise nuko habuze vertebra bituma igice cya brain gishaka kuza hanze cya spinal cord, ariko yubwayo ntiyaje ahubwo hiziye lipoma ahanga noneho myelomeningocele niho igice cya spinal cord nacyo kiza muri ya pouch. As you see this pink area, it represents the spinal cord itself, and of course it has a cerebrospinal fluid. ko murabizi ko ibiri hagati ya meninges and the spinal cord itself. Nk'uko hejuru mu bwonko ibiri hagati ya skull, hari ibiri hagati muri za ventricles, niho cerebrospinal fluid iba yiganje ibiri. So, and you have myelomeningocele. Myelomeningocele ahangaha niho igice cy'ubwonko nacyo cyiza cya spinal cord, mu gihe muri meningocele haza fluid yonyine, noneho na meninges. So meningo refers to meninges. Here myelo will refer to the brain itself, and the meningo refers to the meninges. So myelomeningocele, both the spinal cord, which is like a brain, and the meninges go in the pocket. Here it is only the meninges and the fluid. And so there are some small differences. That's why I said usually it is the biopsy which will confirm which is which, if it is only meningocele or if it is associated and so on. So I think I explained this text here. So another defect is what they call cerebral aqueduct stenosis. So cerebral aqueduct, you know where it is located. So it is located just here, closer to the cerebellum. I think the raw diagram is better to show that. Yes, so it is here. I think you can see my arrow. So here there is an obstruction of the aqueduct here. So it can be a tumor, it can be a blood clot, anything which or obstruct here. You understand the consequences that the cerebrospinal fluid, which is produced here intracranially, will not go down in the spinal cord, and therefore here the ventricles will be enlarged. The ventricles will be enlarged. So the aqueduct is shown here in this diagram. So here also it is here, as I said, below, just anterior to the cerebellum. So this area is sensitive. It can be obstructed by anything. It can be a tumor, it can be a blood clot, and so on, or any other thing. So the consequence will be that, as you see, the ventricles here are small and here they are enlarged. So ntuzasanga umwana ashobora kugira bariya baba bafite hydrocephalus, umutwe wabaye munini cyane, and so on, kubera fluid yuzuyemo hano. So that can be one of the consequences. So congenital stenosis of the channel draining cerebrospinal fluid from the third ventricle into the fourth ventricle. And so the fourth ventricle, you see it, this is the fourth ventricle, and the third ventricle will be here, and here you have the lateral ventricle. So this leads to accumulation of the cerebrospinal fluid in the ventricular space, the most common cause of hydrocephalus in the newborns. You know that this fluid is produced by choroid plexus lining the ventricles, so it is produced here. So the spinal cord itself, there is in the spinal cord area, there is no production of cerebrospinal fluid. The one circulating there is produced intracranially. So the obstruction here will cause the spinal cord to lack the fluid, and the fluid accumulate intracranially. So the fluid flows from lateral ventricles into the third ventricle via the interventricular foramen of Monroe. It flows from the third to the fourth ventricles via the cerebral aqueduct, which now is the concern here. Then it flows from the fourth ventricle into the subarachnoid space via the foramina of Magendie and Ruchka, and presents with this. In this disease, the child will present with enlarging head circumference due to dilation of the ventricles. And you remember ahanga umwana fontanelles ziba zitarifunga, So because the cranial suture lines are not yet fused, that's why umutwe we ukomeza kuba munini, uko fluid yongera umutwe nawo uranguka. So another condition is dandy walker malformation. I think you can see the pictures here. Ichambere kiranga ankanga kuri picture, there is no cerebellum. On this CT scan image here, there is no cerebellum. So congenital failure of the cerebellar vermis develop. Presents as a massively dilated fourth ventricle in the posterior fossa and with absence of the cerebellum in this picture. Often accompanied by hydrocephalus. Hydrocephalus is a diatonal fourth ventricle is very much dilated. So here on this diagram, they are showing that it is usually associated with other maldevelopment, other issues. You see that wajirango have other heads just on the X hospital area. And of course, the cerebellum is lacking here, is not there. Another condition is the Arnold Chiari malformation, type 2, but we have two. Of course, there is also type 1. That's why I added a diagram to show type 1, how it looks like, and the type 2, which is the concern here. So there is a congenital downward displacement of cerebral vermis and the tonsils through the foramen magnum. So I think here you see the normal anatomy. We have the cerebrum and the cerebellum here. We have the pons here and so on. So in a Chiari type 1 malformation, Arnold Chiari type 1, what you have here, you see that a part of the cerebellum is trying to go down towards the spinal cord. So you can compare this diagram to this one. A part of the cerebellum here is descending here. And also for the type 2, it is the same. We have the cerebellum going down, but also we have the brain stem also, which is trying to go down. So I can say that Chiari type 2, it is more dangerous, I can say so, as compared to Chiari type 1. So because of this, if the brain stem goes down, if the cerebellum goes down, they will obstruct the cerebrospinal fluid flow. And so ninga twabonye kuri ile aqueduct stenosis. So the fluid will not flow toward the spinal cord, and this will result also in hydrocephalus. And it is seen that usually these children with Chiari malformation type 2 also they present with myelomeningocele. So urebye muri spinal cord hasi uzasanga afite both. So on the of course there are many diseases of congenital anomaly type that we cannot discuss everything. So here we end with the familial tumor syndrome. It means there are some people who have inherited genes which are mutated, and they are then prone to develop some tumors of the central nervous system. Because we are dealing with this system, I've got tumors. So the first one is the neurofibromatosis type 1. I remember there is a time I discussed, I said this, I think, I don't remember. Was it for many syndrome? So I don't remember that, but I mentioned this. So neurofibromatosis type 1, habaho na type 2, zijya gusa. Gusa ikibiranga nuko type 2, NF2, yo usanga agira tumors inside the intracranial cavity cyane. Naho muri type 1 ashobora kuzigira ariko bafite n'ibindi bimenyetso hanze ku ruhu, ku maso n'ibindi. But here, what we listed here, they are just the tumors of the central nervous system. We didn't, the table didn't include the other tumors, the other lesions. Ariko kuri neurofibromatosis type 1 narabivuze umuntu aba afite utuntu tw'utubyimba ku mubiri dutoya, akenshi ubona ari n'utuntu dusanzwe k'umukara, akenshi ari umukara, ibyo abanyarwanda bita ubutoritonzi cyangwa utundi tuntu. hari abantu b'inzobe bakunda kutugira ugasanga mu maso twajemo, hari uba ubifite ku mubiri wose rero, cyane cyane ari umwana, aho ngaho nibyo biba bigomba kukubwira ko umuntu yaba afite iki kibazo. So for histology, kugira ngo tumenye ko umuntu afite neurofibromatosis type 1, icyo tureho ni iki? Ni uko icya mbere iyo dufite biopsy of tugasanga ni neurofibroma, which is a tumor arising from the nerve, peripheral nerves usually. Icyo dusangamo icyo gihe, iyo dusanze harimo nerves zinyuranamo hagati, icyo gihe tuhita tubyita plexiform neurofibroma. So whenever we say plexiform neurofibroma, we mean this is most likely to be associated with NF1. Otherwise, to confirm NF1 or NF2 mutations, of course, you need the genetic testing. So NF1 gene is found in chromosome number 17, while NF2 is found in chromosome number 22. So Lee-Fleming syndrome, you know this, it is when someone is having a TP53 germline mutations. And you understand bashaka ibibazo byinshi kubera akamaro muzi ka P53 protein. Turcot syndrome, so aba ni bamwe bagira bya bibazo muri APC, adenosis polyposis coli, bagira many polyps within the colon. Twabonye ko abo ngabo when the colon is not removed, then they can develop cancers of the colon. Ariko ntabwo ari byo bagira gusa, so we have many other problems. So is the MLH and so on, is in mutations abantu bagira mismatch repair gene in the abafitemo mutation bagira colorectal cancers also. But it was seen that also these people, they can develop medulloblastoma. We shall see it. It is a tumor rising from the cerebellum. So tuberous sclerosis, it is another condition yango tuzayigarukaho cyane tugera kuri musculoskeletal system. So people having this problem in chromosome number 9, they may develop a ependymoma. You can understand this is a tumor rising from the ependymocytes, the cells which line ventricles, and let's say normally don't around hose spinal fluid inyura muziko on the peripheral area or parietal area haba hari meninges. Ku gice gifashe ku bwonko rero haba hari izi cell bita ependymocytes. A tumor arising from ependymocytes will be called ependymoma, and this is a misnomer. Uyibonye wagira ngo ni benign tumor, but it is a cancer, high grade cancer. These ones, astrocytoma, ganglioneuroma, and so on. Astrocytoma rising from astrocytes. Von Hippel-Lindau's disease, people develop having it, they can develop hemangioblastoma. Sturge-Weber syndrome, these people, they develop the choroid plexus papilloma. Choroid plexus tukagira ngo murabyibuka ngo twanabivuze kare niyo ikora cerebrospinal fluid. So neurofibromatosis type 1 is the most common, and usually people present with multiple peripheral neurofibroma. Nibyo navugaga mu gihe type 2 bakunda kurangwa na acoustic schwannoma and meningiomas. So these are intracranial tumors. Tuberous sclerosis, people, the patient presenting with this syndrome, they have subcortical and cortical hematomas. Nizo zitwa tubers, niyo mpamvu hano haza tuberous. So hematoma nize kwivugaho tureba neoplasia, ni ibintu bimeze nka tumors. But when you look at the histology, it is not a tumor. It is just an abnormal localization of a normal tissue. Ugasanga no hagombye kuba ari smooth muscle gusa, ugasanga hajemo na fat, na ya smooth muscle kazamo na fibrous tissue bigenda binyuranamo, so biteye twita hematoma. But the clinical signs and symptoms of a tumor, because it is an overgrowth, but it is not a monoclonal condition. So this is expressed in an autosomal dominant way, and there are also tumors there are also mutations in the tumor suppressor gene, and there are some cutaneous findings, tumors bafite ku ruhu ahanga, so we shall come back on this in the other chapters. So if you have any question about these developmental anomalies, you can ask it. Otherwise, we will proceed with the spinal cord lesions. Okay, so let's proceed. So serengomyelia, so in spinal cord, serengomyelia, it is a cystic degeneration of the spinal cord. Ngira ngo nta n'ikintu gikomeye kumvamo ahangaha. So here we have the vertebra, murabizi ifite the body, it is anterior, while the iyo twakwita nka spine ubwayo ibiri inyuma agana hanze ku ruhu. So inside niho spinal cord inyura, kandi hagati ya yizi bone and so on na spinal cord hari space inyurwamo na cerebrospinal fluid. So on the parietal part there are meninges, dura. So here you see dura, which is a meninge membrane, and on the visceral area here there will be ependymocytes. Of course, ntabwo ari ikintu ubona because they are just a cell, one layer of cell. So ikibazo hano muri serengomyelia nuko hazamo cavity inside the spinal cord, and this cavity is usually filled with cerebrospinal fluid. In a normal condition, the cerebrospinal fluid must be between the spinal cord and the dura or the meninge. But here it is not the case. We see also the cerebrospinal fluid inside these cavities, which are just inside the spinal cord. So arises with trauma or in association with type 1 anode Chiari malformation, type 1 and type 2. So usually occurs at C8, so cervical vertebra 8 up to T1. T1 or thoracic vertebra 1. Aho ngaho niho ikunze kugaragara. So the patients, urumvikana ntabwo ari ikintu ubona n'amaso, ahubwo there are some signs and symptoms which can appear, then zikakubwira ko yabafite icyo kibazo, ko atari ahantu ubonesha amaso. So they have a sensory loss of pain and temperature with sparing of the fine touch and the position sense in upper extremities. So cape-like distribution. So due to involvement of anterior white commissure of the spinothalamic tract with sparing of the dorsal column. So there is a table that will show that. So ibyo bita cape-like distribution ni ukubera twabonye ko cya kibazo gikunda kubera hano muri the cervical vertebra 8 up to T1, thoracic vertebra 1, aho ngo hakunze kubera icyo kibazo, binatuma signs and symptoms zijya aho nerves zituruka muri icyo gice zinyura, aho zijya niho haba ibibazo. So ku maboko n'igice cyo hejuru, that's why they call it cape-like distribution. So C-length expansion results in involvement of the other spinal tracts, leading to muscle atrophy and weakness with decreased muscle tone and impaired reflexes because there is a damage of the lower motor neurons in the anterior horn. So Horner syndrome with ptosis, droppy eyelid, meiosis, constricted pupil. So these are explanation of these terms. Ptosis, droppy eyelid, while meiosis means a constricted pupil, and the anhidrosis, decreased sweating due to disruption of the lateral horn of the hypothalamospinal tract. So there are many things about the physiology here. So here serengomera of the is depending on where the problem is on the spinal cord. So it is what you have here. So if there is an issue with spinothalamic area, they will present with pain, pain and the temperature sensations will be affected and so on. If dorsocolumn or medial lemniscus are affected, so there will be an issue with pressure, sensation of the pressure, sensation of the touch, vibration, and the proprioception, and so on. If the lateral corticospinal area is affected, now the consequences will be on involuntary movement and so on. So this is just explaining, depending on the location of the defects, there will be some specific consequences. So another disease here, it is poliomyelitis. So it is an infection, of course. It is an infection, but with severe consequences on the central nervous system, and therefore on the musculoskeletal system. So niyo mu Kinyarwanda bita imbasa. So muzi ko bayikingira muri iki gihe ntabwo ubona abantu benshi bayirwaye, ndetse yagombye kuba yarabaye eradicated, ariko iracyakingirwa. So first of all, how does this work? Icyambere nuko iyi ni virusi abantu bandura ikagenda inyuze muri upper respiratory system mu kanwa cyangwa se mu zone so on. So ikazagenda and it will damage the anterior motor horn. You understand this is in the spinal cord due to poliovirus infections. It presents with lower motor neuron signs, flaccid paralysis with muscle atrophy, fasciculations, weakness with decreased muscle tone, impaired reflexes, and the negative Babinski sign. So mwabize muri signs and symptoms cyangwa semiology, Babinski signs and so on, aho intoki amano. So ni uburyo tuvuge niba ukwisa akanyunda cyangwa kandi kantu wenda munsi y'ivi gatoya, reflexes ubundi in normal way nuko aba yagombye amano kuzamuka akareba hejuru, ariko in other conditions bijya hasi. So iyo no hazamo Babinski signs and the other signs that you know. Kirango na hari ahantu muzajya mubona cyane cyane bafite ibimenyetso bya poliomyelitis ni abantu bakuze icyo gihe gukinirwa bitarashoboka. So uzabona benshi abantu bafite imyaka 60 gutya muri iki gihe cyangwa irengaho, abonzi on my side nabo ngabo. So ikibazo cyabo nuko bigeraho hari igihe ataba ari muri crise rwose akagenda acumba gerenda nimba gatari cyangwa afite imwe ikindi yagira crise no guhaguruka bikanga kandi akanaribwa cyane bya fasciculations and so on, akaribwa cyane. So ntabwo buri gihe bameze kimwe, hari igihe uzamubona ameze neza ikindi gihe ubone byanze burundu, maybe because there will be reactivation of the virus. So widening Hoffman disease, inherited degeneration for the anterior motor horn, transmitted in autosomal recessive way. Yango niyo ndwara navuze aho umwana aba ari hypotonic, muscle tone is very low, is very decreased, kandi umutera w'umwana umaze amezi angahe yundi yagombye kuba ijosi rye rikomeye ariko bikanga, and so on. So it is explained here. So amyotrophic lateral sclerosis, this is a degenerative disorder of upper and lower motor neurons of the corticospinal tract. So coming here on this diagram, yeah, this is in a normal nerve. In a normal nerve, so normal nerve cell, it is not a cell. So a nerve, so in nerve, you know, we have a neuron with its axon and the dendrites here, and then around the axons, we have this myelin sheath composed of the oligodendrocytes. And then Izi oligodendrocyte akamaro kazo nuko iyo zihari message ivuye hano igenda irihuta cyane, na za nodes of Familial and so on, nodes of Familial and so on. So byose bituma message yihuta, and ariko iyo habayeho ikibazo nk'izi oligodendrocytes zikaba damaged, then the message will not go, and usually the muscle will not be able to contract adequately as it is here. So there will be a degeneration of this horn, and the consequences will be flaccid paralysis. Ngira ngo iyo umuntu afite paralysis ishobora kuba flaccid, ni hamwe usanga ari hypotonic, cyangwa se ikaba contraction itava, icyo gihe it is the opposite. So there will be muscle atrophy, fasciculation weakness, with decreased muscle tone, impaired reflexes, and the negative obesity sign. So you understand it is almost the same as the in the polio. So lateral cortical tract degeneration. So here it was anterior motor horn degeneration, and I find this is in the spinal cord. While here it is lateral corticospinal tract degeneration is to upper motor neuron signs, which are like spastic paralysis. So spastic, it is opposite to flaccid. Flaccid is hypotonic. Spastic, it is hypertonic. There will be increased reflexes, while here there will be impaired. We understand that they are opposed. Increased muscle tone, while here it is decreased muscle tone, and there will be positive Babinski sign, while here it was negative. So byumvikana ko iyi ya mbere anterior motor horn degeneration ifite sinye nk'iza polio, mu gihe iyi cortical spinal tract degeneration ifite signs which are opposed to those of poliomyelitis. So the atrophy of and the weakness of the hands is another sign. No kuvuga ko ntabwo itangirira icyarimwe hose, itangirira ku ntoki bizamuka. So there will be lack of sensory impairment, distinguish areas from the syringomyelia. So in syringomyelia nta kibazo cya sensory cya sensitivity kiba gihari. Ukuvuga toucher, kumva uburibwe n'ibiki, ahubwo ho hazamo ikibazo cya movements. Ndango murabyibuka muri physiology anterior horn zireba cyane na movement, naho posterior horns zo zikareba sensations. So most cases are sporadic, arising in middle-aged adults. So akenshi abenshi basanze bafite this mutation in zinc copper peroxide dismutase 1, SOD1. And this is in case of familial or familial syndromes. Otherwise, when they say sporadic, it means there is no familial predisposition. So there will be cognitive impairment, behavioral impairment, dysphagia, dysarthria, and so on. So you understand, because the muscles are involved in deglutition. So if the muscles are not working properly, there will be dysphagia. Respiratory insufficiency because of muscle problems again, muscle cramps, spasticity, spasticity and the cramps. Ibi bigomba kuza muri ya yindi cortical terwat, mu gihe muscle weakness and the muscle atrophy will be on the other one, the anterior horn problems. So Friedreich ataxia, this is a degenerative disorder of the cerebellum and the spinal cord. So the degeneration of the cerebellum will lead to ataxia. Ngira ngo murabizi cerebellum ni ishinzwe equilibre. Iyo uhagaze ugahagarara neza, nubwo tuvuga ngo mu gutwi kw'imbere intano ya niho biba controlled, but the cerebellum is the overall coordinator of our movements. Niyo ishobora gutuma uterura ukuboko kwawe ukakujyana ukajya gufata ikaramu ntuyihushe n'ibindi. So igihe cerebellum idakora neza, ntabwo ushobora kubona ikaramu ngo ugende utere uyikoraho, uzakora ku rundi ruhande. cyangwa se gutitira we kwigera movement ntabwo uzahagarara ngo ugende and so on. So that's why ataxia comes with this issue of the cerebellum. The degeneration of the multiple spinal cord tracts will lead to loss of vibratory sense and the proprioception, muscle weakness in the lower extremities, and the loss of deep tendon reflexes. So, what happens? There is the mutation in this FXN. I think this is called frataxin. Frataxin mutation. Ikizayiranga niki nuko hazaho repeat of G, so guanosine, adenosine. This triplet is repeated many times. Nucleotide repeat. So therefore, if there is such mutation, iyi gene yabaye mutated, ntabwo proteine yari kuzakorwa izaba ikoze. That's why there is an absence of the frataxin protein itself. As a consequences, there will be incorporation of iron with sulfur. The incorporation of iron with sulfur is impaired in the mitochondria, and therefore, if the mitochondria are not the mitochondria will have accumulation of the iron, because this iron should react with sulfur. If it is that reaction doesn't take place, accumulation of the ionic iron will happen, and first there will be free radical formation. Cyangwa murabizi ko iron ishobora gutuma kubera ko ishobora kuba kugira electron ebyiri cyangwa eshatu, cyangwa ishobora kwakira electron ebyiri cyangwa eshatu. Muri iyo process ibyo bita Fenton reaction, and then it will create free radicals. Free radicals, you know the consequences: oxidative damage of DNA, proteins, phospholipids. Ibyo byose muri cell injury. Free radicals, they are very dangerous. They react with anything which is electrophile. So ikintu cyose gikeneye electron it can react. So here it is included the residues of DNA and so on. Most of the proteins, the phospholipids will be damaged, and thus membrane of cells will be destroyed because they are composed of phospholipids. So there are many consequences on everything here. We lead to cell death. Cell death. Kuko cell membrane izaba damaged, nta nubwo ari cell membrane y'inyuma gusa, cytoplasmic membrane, even the membranes of the mitochondria, lysosome, all these membranes will be damaged. So if the membrane of the lysosome is damaged, the enzymes will leak, and therefore they will destroy everything they meet. If the mitochondrial membrane is damaged, apoptosis will happen. So you understand that in this condition, then cell death will happen. And if it happens then on neurons, as in this case, you can understand what will be the consequences. So there is an autosomal recessive mutation due to the expansion of the unstable trinucleotide repeated guanosine, adenosine in the frataxin gene. So frataxin itself, a protein, is essential for mitochondrial iron regulation, as we saw on the previous slide. The loss of this will result in iron buildup or accumulation with free radical damage. So this disease is present in early childhood, and the patients are wheelchair bound within a few years. So azatangira kugendera muri mu kagare akiri muto, associated with hypertonic cardiomyopathy also. So we go to meningitis, if no question. Okay, so let's proceed. Meningitis, it is inflammation of the meninges. So nibyo mu Kinyarwanda yita mugiga. Mugiga ni usibye ko mugiga ari a type of meningitis aho umuntu yaterwaga na bacteria yitwa Neisseria meningitidis. Niyo bitaga mugiga, ariko muri rusange inflammation of the meninges nibyo bita mugiga. So inflammation of the leptomeninges. Aho usanga nk'ahangaha hariho pus. There is a pus on the meninges. So meninges consist of 3 layers: dura, arachnoid, and pia, that lie between the skull and the brain. The pia and the arachnoid together are termed the leptomeninges. Nizira zisa naho zifatanye n'ubwonko bwazo, naho dura it is more attached to the skull bone. So the most commonly this meningitis is due to infectious agent. Cyane biterwa na age, and this is very important. Uzagaruka no mu zindi causes infectious diseases. It is important. Niba babonye umwana mutoya neonates utarengeje iminsi 28 afite meningitis, bagakubaza what is the most likely cause? I mean bacteria. You must know that. So we have Listeria monocytogenesis, monocytogenes, iyi nikunda gufata neonates. And also we have group B streptococci and Escherichia coli. In children and teenagers, it is Neisseria meningitidis yandi bakingira, so ntabwo yagombye kugira ko baramenye mugiga barakingira, ntabwo abantu bagombye kuba bakirwara. So others are Streptococcus pneumoniae in adults and the elderly, and Haemophilus influenzae in non-vaccinated infants. Ariko hanga no kwitonda kubera ko Haemophilus influenzae ntabwo batangiye kwikingira vuba nko mu mwaka wa 2008 aho ngaho, ntabwo mbere yakingirwaga muri routine. And another reason is another things you can say here is that there are many serotypes of this bacteria. Ntabwo ari rero zose ziba vaccinated. They vaccinate the most common serotypes, not all. So other causes are Coxsackie virus in children, and this is transmitted fecal-orally. And the fungi, especially immunocompromised individuals, bakunda kugira fungal infections zitera meningitis. So niba ari HIV positive rero umuntu mukuru and bakaza afite signs of meningitis, so you will have to think about fungal infection. So I remember kwakunda kuboha imiti ya fluconazole, if I remember well, ni umuti usa n'umuhondo kandi wicwa n'urumuri rw'izuba cyangwa urumuri rw'itara. So bisaba ko twamuhaga muri perfusion, byasabaga ko tushyiraho amashashi y'umukara kugira ngo urumuri rutica uwo muti. So nowadays, because abantu banduye agakoko ka sida bahita batangiza imiti, ntabwo ari benshi bakigira izi ndwara, these opportunistic diseases. So the classic triads of meningitis are headache, mucorigidity, and fever. So kuribwa umutwe, umuriro, no kugagara igikanu. Kugira ngo kugagara igikanu cyari ikintu cyayobonaga umuntu agagaye igikanu batavuga ni mugiga. Cyane cyane bagafite umuriro, n'abanyarwanda ibyo bari babizi cyane. So others are photophobia, gutinya urumuri, vomiting, and altered mental status. So hari nubwo bagera kuri muri koma birumvikana yatinze kuvuga. So nibyo bibaranga, ngira ngo meningitis mwabigarutse muzakora muri infectious diseases, ariko nibingiye I don't think it should be ntabwo yagombye kuba indwara yakunyuraho ukayoberwa ko umuntu ayifite, ko byaba ari ikibazo gikomeye. Ni sinye zidakomeye kubona ko umuntu afite igikanu cye cyagagaye, donc mwaba ngo narwaye ibikanu, ntahindukira akaba aribwa umutwe, akaba afite umuriro. So ku mwana mutoya ntabwo azakubwira ngo aribwa umutwe, birumvikana. N'umuriro nyine uzawumva, So nuvuga hari ibintu bibiri, ni umuriro uzareba, hakabaho no kugagarigikana. Ikindi kibazo gikomeye ari ku bana bato cyane, hari igihe biba opposite, aho ngo agagarigikana ahubwo akaba hypotonic, nabyo biba. So niyo mpamvu uzasanga umwana mutoya n'igihe adafite rigidity bashobora gukeka meningitis, cyane cyane iyo umwana umuha imiti y'umuriro wa antibiotics zisanzwe cyangwa se wamuvuye ibindi bisanzwe wenda malaria n'iki, ukabona there is no improvement, akagera kuri aho mu confirm ko afite unexplained fevers. Icyo gihe byanze bikunze bamukorera lumbar puncture, bagafata cerebrospinal fluid, wareko nta meningitis. Ko muri indications ku twana dutoya birahari, niba afite umuriro udasobanutse mwashatse impamvu mukayibura, in that case there is an indication to do cerebrospinal fluid puncture. So lumbar puncture, ugafata iyo fluid then bakayipima. So mu kuyipima niyo ukivanamo cerebrospinal fluid, akenshi diagnosis utuyibona utarayijyana no muri labo, kuko hari igihe usanga iriya fluid ubundi izara ari nk'amazi ajya kubamo akantu k'agahondo gakeya cyangwa brown gakeya, ariko iyo yaje kandi aza ari clear nta bintu ubona birimo, ariko iyo yaje ari pass, bitumye ko ari bacterial infection. Hari igihe aza atari pass ariko ari turbulent, ubona ko harimo utuntu tunyuramo utwatwo neza, it will be another type of infection, nka fungal infection cyangwa viral infection. So muri laboratoire icyo bazareba ni icyo gihe muri laboratoire, icyo gihe ugomba no kumufata amaraso bagakompara glycemia, ikigero cy'isukari muri cerebrospinal fluid n'ikigero cy'isukari mu maraso. Iyo muri cerebrospinal fluid isukari yashizemo ari nke cyane ugereranije n'iyo mu bwonko, hari rate izwi normal. Iyo iri hasi cyane bahita bamenya ko ari bacteria, kuko bacteria nizo zikonsoma isukari, ntabwo viruses zikonsoma isukari, because they are not living beings. Bacteria zo zirarya kubera ko they are living beings. So ikindi bareba ni proteins, aho ziyongereye, aho niba zagabanutse ugereranije no muri serum and so on. So at the end, of course, they will have to examine under microscope and see if there are bacteria. If there are many white blood cells, because white blood cells nizo zatuma habaho bizagaragara ko harimo pus and so on. So you just barabikora, then they will know this is bacteria or not, or it is a meningitis, yes, but caused by viruses, and they treat accordingly. So the diagnosis made by lumbar puncture, ngira ngo ni imwe mu bintu mugomba kumenya, nzi ko abantu babitinya. Bien sûr kwa muganga turiga n'ibindi, ariko hari ibyo bamwe bita ngo ni ukuboko kwiza, bakaba azi ibintu azi kubisobanura, ariko byagera kuri pratique bamwe ngo kora lumbar puncture ugafailinga buri gihe. So lumbar puncture ntabwo ari benshi bayigeraho, kuko akenshi nta n'uwinjiza urushinge. Ugomba kubuzi anatomy, ukavuga uti ubu ngubu mvuye mu ruhunge muri masozi, ubungeza ahangaha, ubu ndakeka ko agashinge ubu rwumva uko rugenda, wimagine aho rwaba rugeze, ukimagine ko rugeze handi cerebrospinal fluid inyuma. So yahagera then fluid ugafungura ikaza, ariko hari umuntu ufailinga akabikora bikanga burundu, kandi atari uko wenda n'abandi bamurusha, ugasanga ahubwo umutoya kuri the rest experience niwe ubishobora, ariko buri wese agomba kubigerageza, agomba kubyiga akabimenya aho bazikura. So ikorerwa hagati ya L4 and L5, niho space yenda kuba nini, niho urushinge rwinjiramo very easily. No gashinge karekare, ntabwo urushinge rusanzwe kajyamo, kaba kari flexible kugira ngo katavunika n'isura. So here they are explaining the layers to close the skin, ligaments, epidural space, dura, and the arachnoid. So if there is a bacterial meningitis, there will be a lot of neutrophils. Glucose kagabanuka nibyo nasobanuraga. So then you do gram stain and the culture often. So gram stain izakubwira ngo ni gram negative bacteria gram positive. Then the culture nibwo uzamenya ko izazongera zibe nyinshi noneho bazibone muri microscope bazirebere ubone ni streptococci ni staphylo and so on. Then mukora byane bya antibiogram kureba umuti uri sensitive kuri. In viral meningitis ntabwo azamo dystrophism azarimo lymphocytes as you saw in inflammation. And there will be no more glucose because viruses will not consume glucose. For fungus, there will be lymphocytes and raw glucose. Ngira ngo murabona ko itu tuntu tubiri dukombinye, lymphocyte and glucose, or white blood cell type and glucose. You can easily know this is a fungus, this is a viral, or this is bacterial. So complications usually are seen in bacterial meningitis. Kwa harimo pus, harimo ibintu bya pus bitera consequences. So harimo cyane ko bifunga ahantu umuntu akazagira nka hydrocephalus. Birumvikana mu gihe hari kubaho healing, fibrosis bishobora gufunga za nzira twabonye aqueduct n'ahandi, noneho cerebrospinal fluid ntiyongere guflowinga izire ikagumanya noneho hakazamo hydrocephalus niba yari umwana mutoya. Ikindi it can cause paralysis of, it can cause the damage of some nerves or neurons, ukasanga umuntu atakaje ntagishobora kumva. Ikindi ni seizures. Seizures ni seizures ni ibimenyetso bimeze nk'iby'igicuri agira ibintu bimeze nk'igicuri na nyuma yaba yarakize. These are sequelae. Kubera iki hari ibice by'ubwonko byabaye damaged. Igihe rero kimwe na kimwe ushobora kugera bitewe na needs. Niba ubwonko bwongerewe icyo busabwa gukora bugashaka gukoresha imbaraga nyinshi, then hano hari scar, hari fibrosis, hagahita herekana ko hafite ikibazo, kagira ibimenyetso nk'iby'igicuri. So these are the consequences. So that's all we can say about meningitis. So as the general practitioners, what you have to know is at least to know meningitis types n'uburyo ushobora kubibona nubwo waba uri muri periphery muri health center aho batari bupime za bacteriology n'ibiki, but at least you can do puncture ukayohereza iyo fluid ukireba ukamenya ngo this is bacterial or not, then ukayohereza bakazapima ibindi bakakubwira. So and this is an emergency, of course. This is an emergency. Kubera ko umuvuye ataragira zira fibrosis, ataragira severe damage, azagira less fibrosis and less sequelae. Ariko nakira n'undi byaramutinzeho azagira biriya bimenyetso, usange umuntu wakamuga nyuma atayumva cyangwa se ahorana ibintu bimeze nk'igicuri and so on. Questions? Okay, so let's see the cerebrovascular diseases. So ahangaha niho turabereye mu bintu bya stroke, nubwo hari akandi gace gakurikiyeho turabigarukaho gato. So cerebrovascular disease of the brain ni birumvikana nta kintu kindi wahita wumva ni stroke. So the cerebrovascular diseases are neurologic deficits due to cerebrovascular compromise, the major cause of morbidity and mortality. So it is due to ischemia in 85% of cases and 15 and the hemorrhage in 15% of the cases. No kuvuga stroke irimo ubwoko bubiri ntukabivuga ni ischemic, no kuvuga amaraso ntagera agomba kugera, yabaye obstructed cyangwa se habaye hemorrhage ubwayo. So obstruction niyo ihari nyinshi, ari ahita amazamo atherosclerosis. So neurons are dependent on serum glucose as an essential energy source and they are particularly susceptible to ischemia because they will undergo necrosis within 3 to 5 minutes. I think this we say, I explained this before. So they said that each year, almost 800,000 people in the US will have a stroke, and these are new cases. So a stroke is an interruption of blood flow to the brain. So the types are ischemic, as you can see here, occurs when a clot must block the blood vessel, cutting off blood flow to a part of the brain. Another type is hemorrhagic, occurs when a weakened blood vessel, like aneurysm, ruptures and spills blood into the brain. So, at the end they will be ischemic. Nubwo iyi ubwayo yitwa ischemic, ariko ni ischemic kubera ko iyi blood vessel nicika aha ajya gutunga igice kimwe cy'ubwonko n'ubundi ntazagera. Gusa morphologically izaba yacitse inyuma ahubwo irahita imbere aha ngaha mu gihe ngiyo yacitse. But otherwise ndetse mu bitabo bimwe na bimwe muzasanga ibi byo babita ischemic n'ubu. So the causes are not known in many cases. So diagram ishaka kuvuga. So twavuzemo aneurysm ko rimwe na rimwe icika and also this in hemodynamic changes. I think you remember is easy to understand. So aneurysm rero iyo ishwanyutse haba itazamo hemorrhagic ischemia or hemorrhagic stroke. So the most common type of aneurysm is circular aneurysm. Iyi diagram yerekana iyi ni muri ya Willis trigon ya Willis ni iri kwerekana aho aneurysms zikunda kugaragara. So wana ko nyinshi zikunda kuba kuri anterior communicating artery 40%. Then others ni hano kuri middle cerebral artery 34%, 20% here and so on. Kirango hari ibintu twavuze bya collateral circulation anga mushaka kuyibona anterior cerebral artery na posterior cerebral artery. Wana ko ubundi mwigize ikibazo indi ishobora gufasha cya gice cyageze kitari kugerwaho no tuvuge hano hifunze somewhere here. This posterior one will bring blood that area kubera ko they communicate at the end they communicate. Ndetse nizi buryo nizi umusozi ra communicate yanyago Imana yuzanga kugira ngo hamwe kibazo at least branch of the artery is yohereza ikibazo nuko amaraso agerayo n'undi abadahagije ujyanije nayo ubwoko buba bukeneye muri icyo gice cyabuze ayo gisanzwe kibona. So the diagram irerekana aneurysm. So here we have these vessels, the trigon ya Willis, hexagon cyangwa trigon, remember how we call it, hexagon. So but there is a sac here, a sac in one of the arteries. So this is the aneurysm. So mu gihe uyikuyemo urabona ni kinini ujyanye n'izi vessels and so on. And on histology they are explaining somewhere here the muscular wall and the antemoelastic lamina are absent. So niba hatarimo muscle, even elastic lamina is absent. You understand that this wall is very weak. Kwa ko muscle nituma ikomera ikaba nini. So niba idari rero birose ko gashwanyuka hasi akantu ka adventitia na ka intima gato. That's why it can rupture very easily. Nk'igihe blood pressure izamutse ku mpamvu runaka, so it can rupture. Okay, so this so the global cerebral ischemia no kuba ifata igice kinini cy'ubwonko akenshi ntabwo izaterwa nuko hari vessel cyangwa se ko harimo ateroma atherosclerosis somewhere. Kwa ko ibyo iyo bibayeho biba gace gato. So ni igice kimwe cy'ubwonko kiba iri kibazo n'umuntu agira stroke ukabona ko yabaye paralize agace kamwe k'umubiri. At the global cerebral ischemia, it means almost the whole brain is having a problem. So akenshi icyo impamvu izaba iri kure y'ubwonko izaba ari either low perfusion, nk'igihe ari atherosclerosis iri kure itari imbere ahubwo wenda, or acute decrease in blood flow, such as when the heart cannot pump the blood easily. So this is a shock, a cardiogenic shock. Bazagira a global cerebral ischemia. So another etiology is repeated episodes of hypoglycemia. Umuntu ufite insuline nyinshi cyane ya hypoglycemia aza ubwonko bwe burasuffers. Clinical features are based on the duration and magnitude of the insights. So mild global ischemia results in a transient confusion with prompt recovery. Kanoko usanga, so akenshi iyo uri kwiga cyangwa uri gusoma ibintu byo mu buvuzi, hari igihe usanga wenda waragiye uhura nabyo, ni kenshi ngo si kenshi, ariko abantu batari bake bagira igihe agira akantu kameze nka confusion ntazi impamvu yagateye kandi bigahita bikemuka. So haba hari ibintu byinshi mu muyobya biteye, bishobora kuba iki kibazo cya insulin, bishobora kuba n'ikindi cya glucose cyangwa ikindi. So severe global ischemia results in diffuse necrosis. Survival leads to a vegetative state. So vegetative state ni bavuga ariho ariko atariho, ni ukuvuga aba ahumekeshwa n'imashini ngo wamaze igihe kugira ngo nk'umuntu mashine nyine umutima urakora, ibihaha birakora, ariko ubwonko bwaragize death. So cerebral death niko twabonye rero bavuga ngo ni vegetative state. So ibindi bice birabikora ariko atari umuntu utekereza, ubwonko bwe butagikora, bwaragize ikibazo. So ischemic stroke, this is usually regional, it is not global, as I was explaining. So it results in focal neurologic deficits lasting for more than 24 hours. If symptoms are lasting for less than 24 hours, the event is termed transient ischemic attack. Transient ischemic attack. So ni nkaho ari stroke iri transient, niko twabyita. Iyo bitwaye umwanya nibwo, so hari icyakora ahita ajyanwa ahantu hateye imbere, bahita bamuvura arakira nubwo ntabwo ari uwo muri medical field, ariko ntabwo azi ikintu yarakora. So either it was this transient ischemic attack or another problem. So habaho uburwayi bwinshi. So the subtypes include of ischemic stroke, thrombotic, caused by thrombus. I think I will not explain many things because you have seen this. Embolic, so there is embolism or atherothrombotic. It is atherosclerosis and the thrombus which forms there, and the lacunar. So we shall see the details after this. So atherosclerosis usually develops at branch points, bifurcation of internal carotids and the middle cerebral artery in the cycle of Willis. Results in a pale infarct at the periphery of the cortex. Periphery of the cortex is pale. So, and this was the thrombotic. Another one is the embolic. When there is a thromboembolism, most common source of embolism in the left side of the heart. So, for example, if there is atrial fibrillation, thrombus, then it will be sent via the carotid and so usually involves the middle cerebral artery, results in hemorrhagic infarct at the periphery of the cortex. Then you have lacunar. stroke occurs to hyaline arteriolosclerosis, a complication of the hypertension. So no kuvuga ni atherosclerosis ariko yafashe twa arterioles dutoya niyo bita lacuna. So most commonly involves reticulostriate vessels resulting in small cystic areas, ayuma bayita lacuna, cysts, so lacunes, lacuna areas na nundi hari vide. So involvement of the internal capsule leads to a pure motor stroke and so on. So at least here we must retain that we have lacunar, embolic, and thrombotic types of the strokes. So the consequences now on the morphology, the ischemic stroke results in liquefactive necrosis. There are organs which wherever they are necrotized, zihita either liquefactive or maybe. So ubwonko is a necrosis of the brain, it becomes liquefactive, even here abscess. When you have testis, when they are necrotic, they become hemorrhagic. So I think that you remember. So there will be liquefactive necrosis, so it will look like an abscess. Uzasanga fluid using fluid. Ntabwo iba ari organe bisabirwa. So necrosis 24 hours happens in 24 hours. Infiltration by neutrophils day 1 to 3, and the microglial cells day 4 to 7, and the gliosis above these 2 will issue. So this timing is very important, especially when you will be dealing with forensic cases. So ugasanga umuntu ubwo umuntu yapfuye baravuze bati bamusuzume muri autopsy, ugasanga afitemo wafungura ubwonko ugasanga harimo necrosis cyangwa se harimo gliosis, nuko ibintu bimeze nka scar. Icyo gihe bizagufasha kumenya ngo yapfuye ryari, kubera ko bashaka ati ni abantu bamwishe uyu munsi, cyangwa hari umuntu wamuhaye ibyo kurya n'ibyo kunywa uyu munsi, ubwo nibyo bimugeze ndakoso. Nusanga harizamo gliosis, uzabona ko ari bimaze ibyumweru nibura bibiri, wa muntu azaba afite ko ntabwo azahamwa n'icyo kintu. Ni usanga wenda imaze igihe gitoya kandi bakaba bati yari hari icyo gihe, bazamenya ngo turafata noneho abantu bari kumwe nawe muri ayo masaha 28 ashize, kuko bigaragara ko aribwo ubwonko bwe bwangiritse. So ariho ubwonko bwe bwangiritse, noneho bikaza niba bari kumwe basanze umurambo ahantu bazi igihe yapfuye. So all this will help in it. This timing is very important. So the results, then the necrosis will result in a formation of space surrounded by gliosis, and this is shown in figure 8. Sinyango hano murabona igice kimwe kitari white, so this is necrotized. So intracerebral hemorrhage, bleeding into the brain parenchyma, classically due to rupture of Charcot-Bouchard microaneurysms of the reticulostriate vessels. So kubera ko vessel nini iyo zicitse akenshi ahantu amaraso yuzura haba hagaragara inyuma, ntabwo ari muri intracerebral, it is usually on the periphery. So when there are small vessels which are ruptured, for example, they had the aneurysms, then the hemorrhage will be intracerebral. So the person will present with severe headache, nausea, vomiting, and the eventual coma. So the subarachnoid hemorrhage is bleeding into the subarachnoid space, present as a sudden headache, worst headache of my life. Umurwayi azaza avuga ati ambera umutwe undiye gutya, with nuko rigidity, murabyumva asa nahagize za signs of meningitis, ariko uzasanga nta fever afite. Lumbar puncture shows xanthochromia, yellow hue due to bilirubin. nukuba yagize hemorrhage nk'ejo bundi heme ye irafanyuka ikora bya bindi byose kugeza habayeho bilirubin. Cerebrospinal fluid bisa n'umuhondo icyo gihe, umuhondo ugaragara cyane. So that will be a sign. Kubera ko kuri CT scan cyangwa na X-ray ntabwo iyi subarachnoid hemorrhage wapfa kuyibona, because it doesn't form a mass, a hematoma. Hematoma ikorwa iyo hari subdural hematoma cyangwa se iyo hari epidural hematoma, nibwo ubona mass which can be easy on X-ray and CT scan. So most frequently, the subarachnoid hemorrhage is aneurysm, other causes of venous and anticoagulation. Wari umuntu ufite watakaje factors of coagulation. So berry aneurysms are thin walled circular outpouchings that lack a media layer. So media means the muscular layer. They increase the risk of rupture. Because they lack the tunica media, so so uzasanga rero hari amaraso ari hirya no hino atari muri umwanya umwe bakore pocket imwe, ahubwo ari hirya no hino. So most always at the anterior cycle of Willis, at branch points of the anterior communication. I think this is the same as what we saw for stroke, hemorrhagic stroke. Associated with Marfan syndrome and the autosomal dominant polycystic kidney disease, abantu bakunze kugira. So Marfan syndrome bakunze kugira ikibazo cyo kutagira the defective smooth muscle in organs such as ureter, ariko bakanabigira no muri arteries or veins. So defective muscles. So this is like a continuation of this previous one, trauma, which I see here now, epidural hematoma and subdural iri hejuru ya dura mater. So dura mater ina nkaka kumuhondo membrane k'ubururu. So usually it is more attached to the skull bone. Naho pia mater na arachnoid, they are attached to the brain itself. And then when you have a epidural hematoma, it is between the skull bone and the dura. So here the dura is peeled off the skull and the hemorrhage accumulates here, forming a mass. Now subdural hematoma, it is below the dura, so it is between the leptomeninges and the dura mater here, as you see. So nkuko mubibona hematoma no bazihaye kureri zitandukanye. This is because usually subdural hematoma is caused by a rupture of a vein. Niyo mpamvu amaraso asa n'ubururu, while the epidural hematoma, it is usually due to a rupture of an artery. So ibi binatuma clinically ni ibintu bitandukana. Epidural hematoma iza vuba vuba kubera ko artery ifite amaraso yirukanka cyane abasimbuka. Abari menshi cyane, so bituma yuzura vuba vuba, naho subdural iza gake gake. Uzasanga rero no kwa muganga umuntu azaza avuga ati cyangwa akenshi azaye muri koma avuga ati uyu muntu yagize accident ejo, amusuzuma babona aravuga nta kibazo, aratambuka babona nta maguru ntiyabona cyangwa amaboko, hasuzumye mu nda babona bakanze bumva byose ntari kuviramo imbere ntaribwa, baramubwira ngo nataha. Noneho mu kanya nibwo atangiye kugira ibimenyetso byo kuba confused, birakomeza ahita ajya no muri koma. So iyo bimeze gutyo rero iba ari subdural hematoma, biza gake gake. Ni wa muntu n'abapolisi bari aho abisirayeli bati uyu nguyu nataye nta kibazo, cyangwa abanasi bazana na ambulance bakasuzuma bati uyu nataye nta kibazo, ntagire ikibazo muzamubaka muganga, ariko nta mpamvu yo kumujyana ku bitaro. Ariko epidural hematoma kubera ko amaraso aza vuba vuba, umuntu uyu nguyu ajya kuri accident nyuma gato yayo nyine aravuga, ubona ko nta kibazo, ariko mu minota mike 30 40 atangira kugira ikibazo, confusion, then coma. Akenshi yara no mu maso ari ijisho rimwe ubona ko ryagize ikibazo ubyangije n'irindi icyo gihe byerekana ko afite ikibazo ku ruhande rumwe rw'ubwonko. So then you understand this epidural hematoma will be an emergency kubera ko zombi nta ingaruka zikomeye, ariko epidural hematoma nta n'ingaruka zindi arapfa bidakuwemo kubera ko aya ni amaraso aba aza ari menshi. Icyo bikora ni iki? Ni uko bigenda bisunika ubwonko ntandi bufiteho kujya kubera ko buri muri current. So ahantu honyine bufite bushobora kwisunikira no kujya muri spinal cord. So herniation then it is very dangerous. Niyo kabayeho gatoya umuntu arapfa. So niyo mpamvu iyi ni emergency, bahita bamukora icyo bita trepanation, no gufungura ubwo aya magufa noneho bakagira iyi hematoma bakayikuramo ya atari yacitse bakongera bakayisukira, then umuntu yo ataje infection nta kindi kibazo agira. So akenshi rero is carbon ifora kuyibona kuri nenda scan biba bigoye. Ibayeho agace ntikike akacitse ntabwo kuri sire ubibona ko yahacitse. So I think I explained much about this. For epidural hematoma, the lens shaped region on CT imeze nka crystal yo muri jisho kumeze ubona ari iyo shape ifite. Kubera iki? Harimo convexity ya bone hano, ariko hari na convexity yiremye iyo gusunika ubwonko hano ituma iba nka lens, impande zombi iri convex. Herniation is the erectile complication. Nkuko navuga herniation ituma umurwayi apfa nta kintu. Hari n'igihe usanga herniation yabaye atari uko ubwonko bwashatse kumanuka muri spinal cord, ahubwo bwashatse nko kuva hejuru muri supratentorial area bukinjira muri infratentorial ahari cerebellum. Byonyine hagize akantu kamwe kamanuka ka gyrus kamanuka umurwayi arapfa. Hari abantu bazi bakora gusa basanga ni ka gyrus kamwe kamanutse cyangwa twa gyrus tubiri twamanutse ko twarenze tentorial ubundi agahita. So herniation is very dangerous. So for subdural hematoma, so this is a crescent-shaped region on CT. Kuri epidural, it is the lens-shaped. Here it is a crescent-shaped. Present with progressive neurologic signs. This agace nkora bivuga ko amaraso it accumulates slowly. While here it is lucid interval may precede. So neurologic signs ziza zihuse. Lucid interval ni ene navuze ya minota 20-30 nishira umuntu akoze isakora nta kibazo afite. Uzatinya umuntu wakoze isida agatura umutwe hasi ubundi mwamuvugisha mukana nta kibazo. So you will be very careful. Iyo yagize confusion gusa no kuvuga ubwonko bwabaye shaking ariko nta rabuca ntaki akenshi agira confusion ako kanya. So nusanga agize confusion akanya agikora accident akenshi kiba ari icyo ni confusion, nta n'ikindi kizoretse kumuha anti-inflammatory drugs. Gusa atazihawe nawe kubera ubwonko bugira swelling idima nawe akagira herniation kandi yamwica. So niyo mito gusa mabuka jimbuka nta kindi agatamo. Ariko utagize ikibazo nk'icyo utagize confusion nagikora accident yatwimutwe hasi mwabibonye, yeah, you will be very careful. Ni lucid interval ibiri kuba mu kanya gato uzasanga atangiye kugira ibibazo bito. So for subdural hematoma again, herniation is the erectile complication. I explained this. So herniation then it is the displacement of brain tissue due to a mass effect or increased intracranial pressure. So it can be tonsillar herniation. I added a diagram here to show you. Tonsillar, it is used when it is the cerebellum. Cerebellum iri hano ishatse kumanuka, iyo ishatse kumanuka ikurikira spinal cord cyangwa brainstem hariya hasi. So unko ni igice kiri hejuru muri supratentorial. So tentorium ni aka gace kari aha ngaha. Aha niko kagabanya igice gituwemo na cerebrum n'igice gituwemo na cerebellum. So twakwita ubwonko bw'inyuma cerebellum. Iyo rero hagize igice kiri supratentoriyo kimanutse kikinjira ku infratentoriyo kigasanga cerebellum, icyo bivuga ko unco herniation. Hari izindi yitwa transitentoriyo, ni ukuvuga byavuye ku ruhande rumwe, wenda byavuye muri hemisfere y'iburyo y'ubumoso bijya y'iburyo, aho ngaho izaba ari central or transitentoriyo. Bishobora no kuba transcalvario, ni igihe noneho ubwonko bwanyuze muri bone, skull bone, bugasohoka hanze, wenda bukagwa mu ruhu cyangwa bukajya hanze burundu. Iyi ni transcalvario. Ikaba cingulate or subfaracine, ni aka kantu kari hano hejuru katandukanye hemisfere y'iburyo n'ibumoso ariko anteriorly. Iyo hagize igice kimwe kiva ibumoso kikajya iburyo or vice versa, icyo gihe bazita cingulate or subfaracine herniation. So izo nizo muri rusange herniation zikunze kubaho. Murabona ko aha hose zatewe n'iki, nuko uyu muntu afite masse hano. Iyi masse ishobora kuba ari subdural hematoma. So yakoze mass effect bituma igice cya hano anterior kiva gitambuka kuri pharynx kijya hirya muri inside tentorial, the subtentorial itself, agera gira ziva iburyo zijya ibumoso, or the ankle, the part of the brain, the cerebrum has gone to infratentorial area, or a part of the cerebrum is going down toward the spinal cord, and so on. So we can also have upward cerebral transitentorial herniation. So it is the opposite to tonsillar 1. So it can also happen. But personally, I have not seen it. What I have seen it is this unco. I think it is this unco one I most of the time see. So I think the same things explained here. Unco, what happens, so I think they explained. I don't need to repeat. So that's all for this trauma and hemorrhagic and ischemic stroke conditions. Questions are welcome. Otherwise, we take a break.
Question.
Yes.
Lecturer, I wanted, when we were talking about stroke, the reason that was shown to be leading to hemorrhage was the weakened part of the artery, that when there is hypertension, it ruptures. Doesn't there be any situation where an artery can rupture without having a weak part of it, like that circular thickenings, remember well, but is there always going to be a reason for the rupture to be the weakened part of the artery?
Yeah, I can say so. Maybe the reason of that weakness differ, but there will be a weakness in the wall somewhere. Otherwise, an artery is very tough. It cannot be ruptured very easily. Sorry?
So for the stroke to happen, there will always be an aneurysm.
Yes, in the aneurysm also there is a weakness. In the aneurysm, there is a weakness because we saw aneurysm, usually it is a complication of atherosclerosis. So if there is atherosclerosis, already there is a weakness of the wall. So atherosclerosis complicates into aneurysm, and then aneurysm complicates into dissection or a rupture. So there will be always a weakness. So unless an artery is cut accidentally, hari ikintu kindi kitemye, otherwise there will be always a weakness for it to be ruptured. And now I have seen many cases of cancers invading vessels. but I have never seen even a single case whereby cancer cells destroyed an artery. They just destroy veins and enter into the vein, cancer cells, but I have never seen any case where they enter into an artery. Artery is very tough.
Yeah, thank you.
Okay.
Another question.
Yes.
As a medical professional, a specialist one, if you meet with a condition where there is an accident, and you see the people with with which has affected with that accident, and you think that, or you guess that there is some of them with the subdural and the epidural, uh, what can you do first? Without any materials, just you are a medical profession and you reach there, what can you do first?
Okay, first of all, if you think you think someone is having a subdural hematoma is you cannot you cannot suspect it on the spot of the accident because it comes usually many hours after the injury, so that it can't be. Usually it will be detected one day after the accident. So for epidural hematoma, yes, you can suspect it within a few minutes, 30 minutes after the accident. Of course, you cannot do surgery on the spot. So what you will do is to rush to the hospital for them to intervene. So you cannot do surgery on the spot. Ntabwo ari kimwe no kuba yakomeretse ukuguru ari gutakaza amaraso aho wamukorera hemostasis gafunga atari and so on. So for the brain that is not possible. So it will be an emergency. Niyo mpamvu niyo yaje ku bitaro haba ari emergency, ibindi byose byakorwaga birahagarara, umuntu agahita abagwa. Nta bindi byo gutegura byinshi, mu minota mike agomba kuba amaze kubagwa. Ntabwo so what you will do is just to make sure that patient rushes to the hospital.
Haba hari ikimenyetso cyagaragara byoroshye ku muntu ufite sabuduro mu gihe gitoya bidategereje umunsi umwe?
I said no, nothing. Kuko ni umuntu n'abaganga musanze babereye baramureba bakasuzuma, there is no paralysis, nta confusion, ntaki, ni umuntu utaha mu rugo. Nta kindi kimenyetso keretse uvuga ati bose bajya bakorwa routine x-ray or routine CT scan, kandi nabwo muri iyo minota 20-30 ntacyo wabona kuko amaraso azi kuza gake, na x-ray nta kintu yabona. So for subdural hematoma, it should not be life threatening kubera ko n'undi zagake niyo ibimenyetso bitangiye kuza n'ubundi ntabwo aba ari umuntu wapfa vuba kubera ko ntabwo herniation n'ibindi byahita biba kuri, ntabwo biba vuba. Ariko igihe atangiye ku ikimenyetso cya mbere byanse cyiza no kumuvura hakiri kare, no kumubaga hakiri kare. But the issue is the epidural hematoma. Other things, they are not the extreme emergencies.
Thank you.
Okay. So if we are done with questions, then we can take a break. Then we come back at 10:30. So minota 17 a break. Okay, welcome back to the lecture. So I hope you can hear me and see the screen.
Yes.
Thank you. So we proceed with demyelinating disorders in the central nervous system. And as you can understand, these are the diseases which affect the myelin sheath around the neurons, especially around the axons. And the myelin sheath, as you know, is composed of oligodendrocytes in the central nervous system, while in the peripheral nervous system is composed of Schwann cells. So this is a normal neuron, which is surrounded by myelin sheath on the axon part, and the myelin sheath is just made up of oligodendrocytes in the central nervous system. So in the demyelinating diseases, some of these myelin sheath components are damaged, as you can see, and the others are left. So nk'uko tubibonere uzasanga abafite uburwayi hari igihe bagera kukagira remission agasa n'uworohewe n'igihe izi myelin sheath zindi zongeye gukorwa, because oligodendrocytes are not permanent cells, so they can be replaced by the others. So when others are formed, icyo gihe agikora remission. Ikindi gihe akagira bronchite ni relapse mu cyongereza, igihe zabaye destroyed again. So nuko bahora, but usually there are some triggering factors in each of these conditions. So the myelin sheath, as you know, its function as insulating agent around the axons, and it also improves the speed and efficiency of the conduction of the message in the axons. So oligodendrocytes myelinate the central nervous system, as I was saying, while Schwann cells myelinate the peripheral nervous system. So the myelinating disorders are characterized by destruction of the myelin or the oligodendrocytes, which are the one forming the myelin, and the axons here are preserved. Axons are preserved. That's why this damage is usually it's reversible. It's reversible, but because usually the factors are not known or are not controllable, so although this myelin sheath can be re-established, it usually becomes again destroyed, and so that's why they have many episodes of the signs and symptoms. Yes. Leukodystrophies. Leuko refers to white, so myelin sheath is white, so that's why this word. Leukodystrophies. So myelin sheath is white. Niyo mpamvu ahiganje myelin sheath ariho muri white sheath, naho muri cortex barimo neurons, bodies and so on, harimo ibice byinshi bidafite myelin sheath, so niyo mpamvu hari gray ujyanyije na white matter. And I know, as you know, in the cortex of the brain, niho hari gray matter, ariko biza muri spinal cord, it is the opposite. Gray matter ijyamo hagati na hagati, white matter ikajya kuri periphery. Caused by inherited mutation in enzymes necessary for the production and the maintenance of the myelin. So there are three types here. Metachromatic, this leukodystrophy is due to deficiency of aryl sulfatase. This is an enzyme. So in this case, the sulfatides cannot be degraded, and therefore they accumulate in the lysosomes of oligodendrocyte. So this is one of the types of lysosomal storage diseases. So some compounds they are accumulated inside the lysosomes. So icyo gihe uzasanga cereals urabibona no kuri history that there are some granules inside which are usually positive to periodic acid shift staining and so on. Club disease, here there is a deficiency in an enzyme called galactocerebrosidase. So in this condition, galactocerebroside will accumulate in the macrophages, not inside the oligodendrocyte, but the macrophages. And another condition is an adrenoleukodystrophy. There is the impairment of this is the which is in the autosomal, but this one is the X-linked. So therefore, there will be accumulation of the fatty acids, which will damage adrenal glands and in the brain. So that's what you can say here. So ikigaragara nuko hari these are metabolic diseases usually damaging this oligodendrocyte mainly. So another one is multiple sclerosis. Multiple sclerosis ni indwara ngira ngo yiganje ihangayikishije kandi ahari mu bihugu byacu ntabwo ari nyinshi, because here to say that it is more commonly seen in regions away from the equator. So no kuba ko muri tropical regions it is rare, but in Europe it is very frequent, and I know many research groups which work on this, and even in the research group I was belonging to. Also, I had a colleague who was doing a research on this disease. So they were trying to know exactly if there is some other genetic predisposition which can predetermine who will have a long-term remissions. So remission ni cyagihe umurwayi atagifite signs and symptoms. Uzagira a long-term remissions without signs and symptoms as compared to the others. So I left him when he was still working on that. I don't know yet the results of it. Probably not yet published. So there is the autoimmune destruction of central nervous system, myelin and the oligodendrocyte. So you understand it is autoimmune. The body forms antibodies which come and destroy that person's myelin and the oligodendrocyte, and you see that they don't destroy Schwann cells on the peripheral nervous system. So this is the most common chronic central and in women. So it is associated also who are going to HS2 are more prone to develop this condition. So this diagram is showing what happens. So I have a central nervous system here and so on. So here, this is a normal nerve. We have a myelin sheath around the nerve fiber or the axon. So in multiple sclerosis, you can see that the myelin sheath is destroyed and the nerve fiber or the axon is just exposed. Kandi kimwe nuko twabonye kare, myelin sheath ifite akamaro kayo uretse ako kurinda axon, ariko muzi ko igira n'akamaro ko kwihutisha communication. There's the communication, the information transportation is quicker with this myelin sheath. So the patients will present with relapsing neurologic defects. I was explaining why they relapse, why they have relapse and remissions, with periods of remission, multiple regions in time and space. So clinical features will include the blurred vision in one eye. So of course, you understand it will depend on which part of the brain is more affected. Vertigo and scanning speech, mimicking alcohol intoxication. So I was amazing how yoga, and because of their brain stem is affected. Internuclear ophthalmoplegia, So ophthalmoplegia, it means abasa naho ari pararize ku buryo amaso ye kuduhindukiza amaso ureba iburyo ibumoso cyangwa hejuru no hasi biba bidashoboka, ahubwo akomeza kureba ahantu hamwe, yakenera kureba ahandi umutwe wose ugahindukira, ariko ntabwo ashobora guhindukiza amaso. So internuclear ni term izamo n'ushaka mu literature muzasanga ikibitera nuko murabizi ko hagati ya neuron ni has each neuron has a nucleus, ariko iyo biri muri brain imbere hari ibyo bita nucleus, noneho zitari zo za cell bodies of neurons. So uzasanga icyo bita nuclei zidasanzwe zifite imirimo idasanzwe. So akenshi izo nuclei mu bwonko ziba ziri hagati ya one nerve and another nerve. So for example, nerve 6 and nerve 8, between them hazamo icyo bita nucleus. So hano rero iri jambo intranuclear no kuvuga ko iyo nucleus iri nucleus nubwo iswe gutyo ibifite n'ubundi myelin sheath around and so on. Your nucleus niyo iba yabaye damaged, which is between one nerve and another nerve. Nerve maybe 6 and nerve 8 between them. So hemiparesis, ngo amagambo mumenyere, hemiparesis na hemiplegia batandukanye. Paresis ni pararize ituzuye, ubona ko umuntu wenda aracyarimo akabaraga gakeya, ariko yavuze plegia nuko ari total paralysis. So plegia means total paralysis, or paresis it is just a subtle paralysis. Unilateral loss of sensation because of the white matter, which is affected usually periventricular. Lower extremity loss of sensation, loss of sensation for the lower extremity, or weakness if the spinal cord is the one affected. Bowel, bladder, and sexual dysfunction if the autonomic nervous system is the one which is affected. So hemiparesis and the unilateral loss of sensation is when there is the problem is within the cerebral white matter. So I think it is what is explained on this diagram. So the diagnosis is done by magnetic resonance imaging, MRI, and the lumbar puncture. MRI reveals plaques, areas of white demyelination. So we will find that, as we said, in the brain, the white matter is inside, while the gray matter is on the periphery. So you will find that here in the where we should have the white matter, there are areas which are not white because they have lost their myelin sheath. So if your MRI is muri radiology cyangwa muri imaging mu nkarabyiza no muzabyiga, MRI ibona cyane soft tissues, while CT scan ireba cyane bones. Nubwo n'ibindi bire ni CT scan ibona bone, MRI ibona soft tissues. Niyo mpamvu hano batavuzemo CT scan, ntabwo yabibona ibi. So then the plaques is rero plaques cyangwa sclerosis cyangwa fibrosis niyo byatumye hazamo ijambo sclerosis. So multiple nuvuga ko biri ahantu henshi, sclerosis, you understand the reason. Lumbar puncture will show increased lymphocytes. Why? Twabonye ko ari autoimmune disease habamo antibody, but usually there are also autoreactive T cells which are fight there. So there will be increased immunoglobulin in these antibodies with oligochronal IgG bands on high resolution electrophoresis. This you saw it in biochemistry or hematology. And the myelin basic protein will be also seen in the cerebrospinal fluid. So this will be confirmatory. Electrophoresis ntabwo ariko high resolution ntabwo ikorwa mu hano hose, ni ibitaro bike bikora hano. So gross examination shows gray appearing plaques in the white matter. So gross examination niba ari umuntu bakore biopsy or if this autopsy. Treatment of acute attacks include high dose steroids. So murabimenyere mumaze kubimenyera nubwo ahari mutabyo tumors ariko whenever there is an autoimmune disease, when you want to hurt it, you must use the non-steroid, you must use steroidal anti-inflammatory drugs, steroids. Zigabanya zigatuma za autoreactive antibodies or T cells zihagarara ntizongere gukora damage. So long-term treatment with interferon beta slows progression of the disease. So which affects the myelin sheath is this subacute sclerosing so subacute is not acute, but also it is not chronic, it is in between. Sclerosing, you understand if there is a fibrosis. Panencephalitis. Pan, it means the whole, so it affects the whole cerebrum. So, and there is inflammation, itis here. So it is a slowly progressive neurological disorder caused by persistent infection. So which infection, it can be usually mesovirus. Mesovirus, meso niyo bita iseru. Yes, ni iseru. Ziko barayikingira cyane umuntu akiri umwana mutoya. Ariko hari abantu bakiyifite bikigaragara kandi ngira ngo abo muri age yanjye abana benshi icyo gihe barayirwaye. So abenshi twarayirwaye mu gihe cyacu yari itarakira yari itatangira gukingirwa. So I know ko nayikingiye nzu ubwenge banterura bantara ndabizi bajya kuyikingira. So kubera ko ari bw'inkingo zari zije. So aho ngubu barakingira bakiri bato, but still there are a few cases which are seen. So there is mutant mesovirus infection of neurons. So children, the young adults. So there will be inflammatory demyelinization and gliosis. So gliosis ni kimwe no kuvuga sclerosis cyangwa se fibrosis. So ni ituma hazamo ijambo sclerosing. So new inclusions. So for me who experience the inclusion. So turagere ko iyo serire yafashwe na virus ntabwo iraya muri cytoplasm ahubwo ira muri nucleus. So tuzi uburyo wenda a cell which is affected by herpes virus uko imera yafashwe na cytomegalovirus yafashwe na ni mesovirus. So hari uko bizitandukana, but at least inclusions here it is for me it is easily seen around the nucleus. There is a whitish area that is inclusion within the cell. So it is a progressive debilitating encephalitis leading to death. Due to slowly progressing persistent infection of the brain by mesovirus. Although the infection occurs in infancy, neurological signs arise years later during childhood. So there will be viral inclusions within the neurons, gray matter, and the oligodendrocytes. This disease doesn't affect only the oligodendrocytes or white matter, but also the neurons themselves. That's we find the issue, the sclerosis here is not only in the white matter, it is also in the gray matter. Ngirango ni nayo mpamvu hazamo ijambo panencephalitis. Muri multiple sclerosis twabonye ko ifata white matter yonyine, ntabwo ifata muri gray matter, kuko muri gray matter ntabwo dufitemo myelin sheath. Ariko iyo kuko ifatana neuron which are in gray matter and in white matter, so it affects both parts of the brain. So progressive multifocal leukoencephalopathy, it is caused by a virus called the GC virus of oligodendrocytes. So it is seen more in people who are immunocompromised, such as AIDS patients or leukemia patients. And because when someone is having immunosuppression, there will be the activation of the latent virus. Ngirango mwabize muri virology virus ko latent cyangwa chiritic and so on. Epstein-Barr virus ko latent ni igihe yafashe umuntu ikinjira muri B cells, memory B cells ubundi zikigenda. icyo gihe biri latent, nta kintu biri gukora na gito ibiryanyumaho. It will be reactivated because of something, either immunosuppression comes or uwo muntu agize indi ndwara nka malaria cyangwa indi ndwara iri severe, nibwo ya virus izaba reactivated, otherwise it will be in latent phase. So then the patient will present with rapidly progressive neurologic signs such as visual loss, weakness, dementia, leading to death usually. So here it is explained. So mnaona kwa virus ni orophacal transmission, maybe oral transmission ikagenda, then it will damage many areas containing the brain. Centropontine myelinolysis. So there is a lysis myelin sheath in the pontine in the pons on the, you know where the pons are in the brain, in the anterior brain stem. So there will be focal demyelination due to rapid intravenous correction of hyponatremia. So iyi ndwara twavuga ko ari indwara iatrogenic, because it is what healthcare professionals have done. So you have done, you have worked hard to correct hyponatremia, but now you see the consequences. So it happens mainly in severely malnourished patients, alcoholic patients, patients with liver disease. Clinically, the signs and symptoms, there will be acute bilateral paralysis. It is called locked-in syndrome. So here, so there is an issue of similarity. There is hyponatremia. The cell is adapted to decrease osmolarity. Then, if you do rapid correction of that osmolarity, the osmolarity difference between the two compartments, for example, the extracellular fluid and so on, this one is the one causing problems. So there will be cell dehydration. So that is a mistake. Dehydration and the disruption of the brain blood barrier and so on, exposure of glial cells to cytokines complement the inflammation. Then there will be axonal shear injury and then the demyelination and the apoptosis. So muri rusange cyo hano bashaka kuvuga niki nuko umuntu afite hyponatremia, icyo ukora kugira ngo wivure no kumwongerera sodium birumvikana. Iyo uyimuhaye rero vuba vuba no kuvuga niba ushyize muri serum muri lactate ikagenda vuba vuba bizatera ikibazo, ariko nuyimuha gace gace kagenda gake ntabwo bizatera ikibazo ko selile zamenya uko yadapta. So if the cell was adapted to decrease osmolarity or the hyponatremia, then you will have to correct it or to correct the hyponatremia slowly, so that cell will also normal. Ni numuha sodium nyinshi, icyo bizatera nuko bizatera amazi yari muri selile imbere ziko akurikira cyangwa sodium ikurikira concentration. So igihe amaraso azaba yaje kubera ko ni barrier yacitse yagize ikibazo disrupted, igihe hazaba haje amaraso afite sodium nyinshi, kugira ngo habeho ekilibre amazi azava muri cell aze hanze kugira ngo concentration of the sodium ibe iko hanze ya selile n'imbere muri selile. Ibyo bizatuma hahitabaho cell dehydration. Kubera ko rero biba ari ikintu kibaye vuba vuba, ya selile zaba injured. Then this is what they are explaining here. So I personally don't know why this will affect only these pons, why it doesn't affect the other organs. Maybe they are more sensitive to that. There's a changes than other cells. But this is what happens to them. So the next is the dementia and the degenerative disorders. Degenerative biza gusa mu busaze. So demyelinating and degenerative, they are different. So demyelinating, anything destroying the myelin, while the degenerative, not only myelin, but also other parts of the brain can be degenerated. Amaseri agapfa agasimburwa n'ibindi cyangwa akazamo deposits. So these are characterized by loss of neurons within the gray matter, often due to accumulation of protein, which damage neuron. Maybe mpamvu hazamo ijambo dementia. Ko muri myelin issues ntabwo hazamo dementia uretse indwara imwe iriya twabonye panencephalitis kuko yaffecta byombi gray and white matter. Gray matter, which is that's the cell bodies of the nucleus of the neurons. Otherwise, ikintu kijyanye no kwibuka kwibagirwa kireba neurons ubwazo, mu gihe ibireba myelin shift ireba movement, uko sensation and so on. So memory now comes to the neurons. That's why ibije hano kurusha uko byaje mu zindi parts that we saw. So often due to accumulation of protein which damages neurons, degeneration of the cortex leads to dementia. So cortex, which is gray matter, which is rich in cell bodies of neurons. Degeneration of the brain stem and the basal ganglia leads to movement disorders. So the most common is Alzheimer disease. You have others: frontotemporal lobar degeneration, Parkinson disease, Huntington disease, spinal cerebral ataxias, and the amyotrophic lateral sclerosis. So ngira ngo inyinshi muzaye mubona abarwayi bazifite cyane cyane wenda amyotrophic lateral sclerosis, Parkinson disease, noneho na Alzheimer disease. It is very common. Ahubwo nuko abantu batayivuza ko nta n'ikindi wenda kuyikora. Ko ni indwara ifata umuntu akenshi akuze tewe na za amyloid n'ibindi, nta kintu kinini ufite cyo kumukuraho uretse support. Ko ni navuga ko niba neurons zarabaye damage nta kindi cyenda kuzisimbura. Kandi bizwa uko umuntu akora. So Alzheimer disease is a degenerative disease of cortex, the most common cause of dementia. The most common features are a slow onset memory loss. So atangira yibagirwa bati nibagira ajya kuvuga kanaka akamwibagirwa rimwe na rimwe kuko ari n'umuntu ukuze kagira ngo ni n'urwenya arimo cyangwa ari gutera ubuse, naho byaraje. Akenshi uzasanga n'abantu atangira kwibagirwa iby'ubu, ariko ibyo mu myaka y'1950-60 by'intambara wenda zari zihari mu Rwanda, ibyo gushyiraho repubulika, ugasanga ibyo arabizi neza n'amadetayi yose arayakubwira abantu ibyo bakoze n'aho bari bahagaze, ariko iki cyumweru akabibona cyangwa se nabe azi abana bakuze zidetaye kuri bo, ariko abana bato rimwe na rimwe bakaba bati umwana n'uwandi kandi ari begins with short-term memory loss and progress to long-term memory loss. So nuko atangira yibagirwa ibyavuba, kuko uyu munsi yibagiwe ibyabaye umwaka hashira iminsi ukabona yibagiwe n'iby'umwaka washize, wenda nyuma y'imyaka ibiri ukazasanga yibagiwe n'ibyabaye mu myaka 1970 and so on, kugeza ubwo azibagirwa ikintu cyose none. So loss of learned motor skills and language, motor skills, learned motor skills, yarazi kudoda noneho nta kibizi, cyangwa se ibindi by'ubukorikori yarabizi nabyo nta kibishoboye, yarabyibagiwe, atari uko adafite imbaraga, ahubwo nuko nyine coordination aho byakorerwaga itagishoboka. Language nabyo birashoboka, yavugaga indimi runaka akazibagirwa burundu, ni ugusaza, ariko nyine tubyita ko ari ubusaza, ariko urumva ni uburwayi. Changes in behavior and personality, akakora utuntu turi bizarre nk'uko abantu bagaye mu mutwe rimwe na rimwe, ariko agatangira kugira umushiha n'isoni. Ibyo byose turabibona. Patients become more mute and bedridden. So abasa naho atangira kwivana muri society, akaba akiri interested in the society and so on. Infection is a common cause of death. Kubera kuba bedridden, so guhora aryamye adashaka kujya hanze mu bandi, so bagira za bed sores, guhora uryamye udakora siporo ni infection, respiratory infections and so on, bikaziramo then nibyo bigahita. Focal neurologic deficits are not seen in rare diseases. So focal neurologic deficit no focal no kuvuga kugira twa paralysis kugira rino maybe urinary incontinence n'ibindi, ibyo ntabwo biza mbere, akenshi biza nyuma. Ikibazo niyo binaje rimwe na bimwe ubifata ko ari ugukora ko umuntu ukura n'ubundi wenda sphincter ze ntizikora neza, ni ibisanzwe niyo ataba afite Alzheimer disease. So muri rusange ni ibyo kuri iyi ndwara. So ni ibintu uzabona abantu bashaje benshi bazafite bimwe muri ibimenyetso. So kubitandukanya ko ari ugusaza cyangwa se ari ukugira Alzheimer disease ntabwo biba byoroshye, cyane ko n'ubundi muri izo kese zombi nta n'imiti wenda kumuha yindi, hari ishobora kumufasha wenda afite nka za focal neurologic deficits n'ibindi, ariko are sporadic and seen in elderly. As I was explaining, risk increases with age, doubles every 5 years after the age of 60. Kuvuga nyuma y'imyaka 60 yo kurema disease igenda yikuba kabiri uko buri myaka 5 ushize. So there is a problem of this is the eta4RL of apolipoprotein A, which is associated with increased risk, and eta2RL, so with decreased risk. So muri apolipoprotein gene, so RL E4 it one more prone to disease, while eta2 is not. So RA onset Alzheimer's disease is seen in familial cases associated with presenilin 1 and presenilin 2 mutations. Down syndrome commonly occurs by 40 years of age, and diagnosis made by clinical and pathological correlation. So presumptive diagnosis is made clinically after excluding other causes. So ukabona afite nk'ibyo bibazo neurologique, ukabona se afite nk'akabyimba mu mutwe katumye bapararize cyangwa se sphincter zidakora neza. Then if you have excluded the tumor and any other possible mechanism which can explain what you see, then you will confirm by excluding or other causes. Then you will confirm, not confirm, you will presume this is Alzheimer's disease. But the diagnosis is definitely done, confirmed using histology, or sometimes at autopsy. Gusa akenshi cyangwa na x-ray ubwayo, ikintu cya mbere muri Alzheimer's disease ni uko ubwonko buba bwarabaye butoya. Neurons the person has lost a lot of neurons, then ubwonko buba butoya. Gusa ibi binagaragara mu bantu bakuze bari bose nubwo atafite Alzheimer's disease, so it is not confirmatory. Umuntu ukuze n'ubundi neurons zaba ntoya n'andi masiro ubwo aba mu bwonko naragabanutse, then ubwonko buba butoya, ukabona a space between the skull and the brain itself iba nini icyo gihe, ku buryo abangaba no niyaguye biroroshye ko agira za hemorrhage umutwe. Kubera iki? Kubera ko utwatarizi twe tuba turi ari nk'udushumi turi aho tudafite supporting tissues around. So igihe ubwonko bubaye shaked by shaking aguye cyangwa any other reason, biroroshye ko za vessels zicikagurika vuba then akagira hemorrhage ku buryo bworoshye ugereranyije n'abandi because of the brain atrophy. So the morphological features include so kuri autopsy cyane cyane ko ariho bikorwa ubona gute GI narrowing. GI ni utu anatomy, so tumeze nk'utuntu tubyimbye ku bwonko, noneho hari ahitsemo hasi n'ibyo bita sulcus if it is one, or surusa if they are many. So they are wide while GI are narrow, and the ventricles will be larger, of course, and neuritic plaques Extracellular core comprises of amyloid with entangled neuritic processes. Seen in B, uzasanga neurons z'ubwazo zifitemo muri cell body around the nucleus harimo deposits of these amyloid and so on. Amyloid may also deposit around the vessels, increasing the risk of hemorrhage. Neurofibrillary tangles, intracellular aggregates of fibers composed of this tau protein. So tau is the microtubule associated protein. So there will be loss of cholinergic neurons in the nucleus basalis of mainnet. So that's what you can say. So ariko ni indwara twavuga yiganje. So treatment will be supportive. I know there are many research activities going on. So there was this a PhD student. They were doing a research on this, on it, trying to develop a drugs which can hurt when it is there, at least to stop it. But it is not in one center, in many centers. So now, nta muti uriho uvura burundu uhari, or at least uyihagarika ngo ye gukomeza guprogress. Kubera ko kwivura bivuga gusubizaho neuron, which is not possible until now. Vascular dementia, there is a multifocal infarction and injury due to hypertension, atherosclerosis, or vascularitis. So it is the most common cause of dementia. So dementia is somebody sounds medical term usually used in psychology or psychiatry or mental health. Ishaka kuvuga ibintu byo kwibagirwa muri rusange. So the risk factors are listed here: diabetes, hypertension, metabolic syndromes, age, stroke, genetic factors. So they will have behavioral symptoms such as the memory loss, slow thinking, depression, anxiety. I think all this you understand. Kwibagirwa cyane, slow thinking. Asubiza akabanza agatekereza nk'aho ari imibare yo gukora, and depression. Okay. Dysarthria, autonomic dysfunction. These are locomotor problems. And then loss of executive function. Ashobora gukemura ibibazo, ari umuntu wenda ari umubyeyi usanga umutura ibibazo akabikemura ko umutura ikibazo reka abona asa naho atabaye imbere nk'umwana uri gukina. And so on. So peak disease, peak, so they make like an abbreviation: progressive degeneration of neuron, intracytoplasmic peak bodies, cortical atrophy, knife edge gyri, and so on. So these are manifestation nuko bajya kuzihina none ngo ongera gape n'ijambo peak. So peak access are peak away and at the old woman's cerebral cortex. So it affects the cerebral cortex where you have neurons, of course, causing a cortical atrophy. So two peak acts on her brain. So frontal lobe and the anterior third of the temporal lobe, nizo zikunze gufatwa. So as you see, so it is a degenerative disease of the frontal and temporal cortex. It spares the parietal and occipital lobes. So usually things they are not explainable. Anterior lobe, posterior and the parietal lobe as so no explanation. Characterized by round aggregates of tau protein, the one we saw also in the Alzheimer disease. So these aggregates of tau protein is peak bodies. In the neurons of the cortex, there will be behavioral and language symptoms which will come earlier than others. And then the patient will develop dementia. So Parkinson disease, degenerative loss of dopaminergic neurons in the substantia nigra of the basal ganglia. So you understand here, the previous one, the peak disease affects the cortex, anterior at the temporal and the frontal lobes, while the Parkinson affects the substantia nigra in the basal ganglia. Here, so umubwonko haba harimo uduce twiganjemo neurone dusa naho turi imbere muri white matter. Twari nitwo bita substantia nigra. Nigra ijambo nigra means black. So there is a black substance inside the white matter. That is in normal conditions, as you can see here. In this area, basal ganglia, in the basal, in the but when there is a Parkinson disease, this substantia nigra is not seen because the neurons are lost. So very white, as you can see here. I uses the dopamine to initiate seen in 2% of all adults. The cause is not known, but there is a connection to exposure to this compound, the MPTP, which is found in illicit drug users. So those who use the drug abusers is that so clinical features, they are summarized into what you can call a TRAP. T, tremor, rigidity, akinesia, and postural instability, and shuffling gait. Shuffling gait. So abantu bafite Parkinson disease ikintu kibaranga nyango birahanga aba tremor, so aba atita nkinshi ubona zititira rimwe na rimwe ubona umuntu akona atitira n'ahandi. The rigidity in the extremities, akinesia or bradykinesia, slowing of voluntary movement, expressionless face. Expressionless face no kuvuga ubona nk'umuntu utayizi icyo yitayeho n'icyo ushaka kuvuga ahangaha, ariko cyane cyane bitewe nuko muvoma z'amaso niba ari kwishima ntibiza vuba kubera cyangwa binagaragara hari amasozi tugomba gukorwanisha. Postural instability and shuffling gait. So ni umuntu ugenda atera udutambwe duto twinshi vuba tambwe tuki kandi agenda asa n'ushaka kugwa imbere. So ubona ameze nk'ugiye kugwa imbere n'ibyo bakana bashaka kuvuga. Agenda ataba ariko agatera udutambwe duto kuko ari two ashoboye. Nibwira ko hari abantu benshi bakomeye bagiye barwaye indwara nyagari. For Jean Paul wa kabiri ngira ngo ndumva rero ibyari bizwi ko ayirwaye, but there are many others. Parkinson disease. So histology will reveal loss of pigmented neurons in substantia nigra and around. There was enough inclusion of alpha-synuclein. So ibyo bita Lewis bodies shown here in the affected neurons. So they have dementia, but usually it's rate. Early onset dementia is suggestive of Lewy body dementia, which is dementia, hallucination, and Parkinsonian features. Histology will reveal cortical Lewis bodies. So the who ntabwo ibyo bayita Lewy body dementia. So nyango hallucination ni amaterime mwiza muri bijyanye na psychology. Hallucination ni kwa kundi umuntu avuga ngo jewe ndi kubona wenda hari imodoka kandi nta kintu gihari, cyangwa ndi kumva amajwi yambwira ngo jya hariya n'ibindi. So visual hallucination kuvuga ngo arabona ibintu kandi nta bihari. Cyangwa auditory hallucination, mu gihe ndi kumva amajwi ari kumbwira ngo genda ujye mu ijuru cyangwa se genda ujye gusura umuntu amusora. So ibintu bitari nibyo bita hallucination. So Huntington disease, there will be degeneration of GABAergic neurons. Like Parkinson ari dopaminergic neurons. Nukuvuga zikoreshwa hano zikorana na dopamine noneho nikoreshwa na GABA in the caudate nucleus of the basal ganglia. So autosomal dominant disorder due to mutation in chromosome 4 characterized by the expanded trinucleotide repeats of cytosine, adenosine, guanine in the Huntington gene. Urabona ko gene akenshi bayahawe izina baramaze kuvumbura indwara yavuye muri Huntington, then bamenye gene iba ifite ikibazo iyo ndwara ije repeats during spermatogenesis leads to anticipation. Ukuvuga indwara isa hakiri kare manifests as early as possible. It presents with chorea that can progress to dementia and depression. Average age of presentation is 40 years. Suicide is a common cause of death, maybe because of that depression. So normal pressure hydrocephalus. So increased cerebrospinal fluid resulting in dilated ventricles can cause dementia in adults, usually idiopathic. Idiopathic meaning the cause is not known of that. No kuvuga hydrocephalus irimo ariko ntabwo pressure intracranial cavity pressure ntabwo iba yiyongereye nkuko muri zindi za hydrocephalus zifata utwana zisanzwe yatewe na obstruction nkuko bimeze. Presence as a triad of urinary incontinency, gait instability, and dementia. So bashatse gukoresha amagambo atangizwa na W, weight, wobbly, and worky. Weight refers to this urinary incontinency. Wobbly nukwera aba afite gait ni ingendo. Instability murabona ko uyu muntu agenda ukuguru kumwe kwa atandaraje niba ari kutuvuga mu Kinyarwanda bango agerageza kugira equilibre. So that is wobbly, and then for worky it refers to the dementia. So it is again explained here. So weight refers to the water or urine. Wobbly refers to walking, and the worky or weight refers to dementia that this have. So lumbar puncture will improve the symptoms. Lumbar puncture uzabugabanije cerebrospinal fluid. But the treatment is ventriculoperitoneal shunting. So ngira ngo muzabibona muri abana bafite hydrocephalus buriya bavura ntabwo ira fluid bayisohora hanze kuko irimo proteine zishobora gukenerwa n'umubiri. Ahubwo bayohereza muri peritoneal cavity. Noneho umubiri ufite uko uramo ibyo ukeneye bisobanutse nibyo muzamubona bakora, niyo mpamvu shunting niyo bakora ku bantu bafite hydrocephalus. So spongiform encephalopathy ibi so ni indwara cyane cyane ikomoka somewhere bovine. So we shall see it. So it is related to the bovine issues. In alpha helical configuration. So the disease will arise with the conversion to beta-pleated conformation. So how could you give alpha helical configuration ikaba beta-pleated conformation? So mirango abaziga ibyerekanye na proteomics no kuvuga structures of proteins muzabibona proteine kugira ngo ikore akazi kayo ntabwo gusa ari ukuvuga ngo acide amine zikoze n'izazindi no hazamo n'uburyo y'ubwayo forume ya protein. So I had a colleague, he was a postdoc in our research group. So he comes from Iran. So we akazi ke yakoraga muri research group yacu nako gukora protein. So hajyamaraga amezi 3 akora protein yaranze kandi acid amino acids zihari ziteranye neza ari kwiconfigure nk'ukuzirika kumwe cyihotora cyihoteye mu yihe sanse, ibyo byose so ntabwo ari gusa chemical composition, also the configuration is very important for proteins to work. So nibyo bibahangaye. Iyo rero iyo prion protein iri mutated igira ikibazo gikomeye kubera ko ni protein ifatwa nk'aho ari infectious. Ni ukuvuga ugize ibyago ukayandura, ni nk'uko wanduye virusi. Mu gihe ubundi proteine ni ikintu cyaba gisanzwe, ntabwo nk'umunyurambere cyangwa iki, ariko so iyo umuntu ayanduje undi cyangwa yanduye ku nka, it is dangerous. Niyo mpamvu niyo if you think a patient is having that disease, you will be very careful. Uzamuvura wirinze nk'uko abantu bavura umuntu urwaye baba birinze. Ikibazo cyayo no mu gihe izindi infectious diseases zicwa na formalin iriya dukoresha muri histology in fixing tissues. This is a protein, it will not be killed. Niyo mpamvu no muri histology, when there is a suspicion of prion disease, we make sure we handle that case very carefully. So pathological protein is able and converts normal protein in form resulting in a vicious cycle. So there will be damage to neurons and the glial cells, and this is characterized by intracellular vacuoles, spongy degeneration. So murabona ahantu h'umweru hano hahuzuyemo vacuoles inside the brain. So one of the subtype of this spongiform encephalopathy niyo bita Creutzfeldt-Jakob disease, ari nayo yiriya nono y'indwara y'ibisazi by'inka. Ngira ngo hari bikunda gutera bakavuga ngo njya mu gihugu cy'Ubwongereza no biherutse mu myaka yashize, hari indwara y'ibisazi by'inka. So when it is rare there, ni nkuko bangwe Ebola yateye. Kako zirapfa, inka ari nyinshi zirasara cyambere undi zigapfa, then umuntu wakogize en contact niyo nka yaba mata yayo yaba kurya inyama yayo cyaba kuyikoraho nabo barafata. This is a contagious protein, although it is not an infection, but it is a contagious. So then if a man is affected or a human is affected, there will be a rapidly progressive dementia associated with ataxia because the cerebellum is involved, and the statomyoclonus. There will be periodic sharp waves seen on EEG. This is electroencephalogram. It results in death, usually within 1 year. So, ngira ngo byandi bya medical biri hano. Exposure to bovine spongiform encephalopathy or medical. So that's all. So I can say that so far what we covered here, it is like a neurology. Murabizi, for those who do this specialization, so ibi byose tumaze kubona ntibibagwa uretse wenda ziriya za hematoma, ibindi byose ni indwara z'umubiri. So they are treated in internal medicine or pediatrics. Ariko hematoma na tumors, they are treated in surgery. So nushaka gukurikirana ibibazo by'ubwonko n'ibijyanye nabwo in non-surgical way, uziga ibyo bita neurology. Nushaka kujya mu byo kubaga uziga neurosurgery. So they are completely different. So neurology, akenshi bari umuntu wize medicine and internal medicine as a specialist in internal medicine or pediatrics, then they will add subspecialization in neurology. While for neurosurgery, usually it is a surgeon who subspecializes in neurosurgery. Yarabanje general surgery cyangwa se hano mu Rwanda ho atangira n'ubundi akora neurosurgery, ntabwo babanza gufata general surgery. So ntabwo rero baba bakora ibintu, hari ibyo bashaka guhuriraho bajya inama, ariko nta department zabo ntaho ziba zikuru. So see also kurusha neurosurgery, but in practical way, of course, surgery, it is more sensitive than the non-surgical one. So basic principles of the tumors of the central nervous system. But if you have questions, you can ask them before we proceed. Any questions? Okay, then we proceed. So I will make sure we are done with this. So we are left with like 12 slides. So we'll finish them within 20 minutes. System can be 50%. Metastatic cancers are multiple and ngira ngo inagumye mbitindaho kenshi metastatic disease kuri brain ku bihaha ku mwijima they are multiple. Where is circumscribed regions in the gray or white in gray matter white matter junction naho ngaho metastatic regions kunda kuba. So ntabwo ari kenshi uzibona ziri muri white matter hagati cyangwa muri gray matter hagati. So usually they come from lung, breast or kidney. And hear me. So of internet. Can you see still the screen?
Yes.
Okay, I assume.
Yes.
So, okay, thank you. So the primary tumors are classified according to the cell type of origin, either from a astrocyte, from an endothelial cells, from a ependymal cells, from oligodendral sites, from neuroectoderm cells or neurons themselves. So ikintu cya mbere hano ugomba kumenya, this is important, it's information ngomba kuvuga zituma umenya. So when they discuss, to know, also to give your opinions. So mu bantu bakuru tumors usually are supratentorial. Mu bana tumors they are usually infratentorial. Mu kuvuga ku bana tumors nyinshi ziri mu bice bya cerebellum, mu gihe mu bantu bakuru tumors usually they are in cerebrum. So cya gice cyo hejuru kinini cy'ubwonko. So the most common tumors in adults they are glioblastoma multiforme. Ubu ngubu muri classification w'iki gihe multiforme ijambo bari kurikuramo bakagumana glioblastoma gusa. So which is a very aggressive cancer itanavurwa itavurwa. So the neurosurgeon kubera ko iyo uyibaze ari glioblastoma, yes ushobora kuyikuramo ariko ntabwo ushobora kuyimaramo, kandi mu gihe gitoya ihita izamuka, noneho aho wabaze ntabwo hongera guterana, ahubwo usanga amagufa yiyegutse nubwo ukabona ubwonko buhora buri hanze. Ati rero ntabwo iyo tubimenye mbere ko ari ntabwo tuba tukimubaza. Cyaba ati nta n'imiti ihari. Ingero z'abantu babiri sinzi impamvu byabayeho, abantu babiri bombi biyamamarije kuba abaperezida ba Amerika mu bihe bitandukanye ariko mu myaka itari myinshi ishize, bose bagize iyi ndwara glioblastoma, kandi ese umubare ugiye kuba perezida wa Amerika agapfa nta muti ahawe nuko nta muti. So it is a dangerous disease. So we have meningioma arising from meninges and schwannoma from Schwann cells. So murabibaza Schwann cells muri central nervous system zisama ko harimo oligodendrocytes. So impamvu nuko ziriya cranial nerves zirava cranial nerve 1 kugera kuri 12 ngira ngo iyo isohoka muri brain mbere yuko iva muri intracranial cavity, aho ngaho iri lined still, to be lined by Schwann cells, not oligodendrocytes. Niyo mpamvu schwannoma abantu bayigira intracranial. So in children, the most common is the pilocytic astrocytoma, ependymoma, and the medulloblastoma. So primary malignant central nervous system are locally destructive, but they metastasize very rarely. So nta handi zijya nyine naho they destroy just around there, and they the tissues are. Angangi hari avuga nuko na benign tumors of the central nervous system, they are dangerous, they are lethal. Zirica kubera iki? Ni si uko uguze ubwazagombye kwica, ahubwo nuko zituma mu mutwe hazamo cya kintu cyo kubura space. Niba zibyimba ubwonko nta handi bufite buhungira, mu cyangwa icyo bakibona kibyimbira gisunika ubwonko, then bukaba bwamanuka za herniation, then mu Rwanda nuko bapfa, increasing intracranial pressure. Niyo mpamvu nabivuzeho cyangwa se niba ntanabivuze ariko nuba nabivuze muri cancer registries, aho bandika abaregisteringa cancer zose zabonetse, niyo ari benign tumor of the central nervous system bayandikamo, because it has the same consequences as a cancer. So this is the WHO classification that I have taken from the recent classification of the WHO. So ikibazo rero gihari muri iki gihe, WHO uburyo classify tumors igendera kuri molecular Africa, ni nuko tudakora ibingibi, ntabwo ahenshi nta bushobozi bari bwo gutestinga these mutations and so on. So aho ari challenge, ntabwo ari kuri central nervous system gusa, no kuri blood cancers n'ibindi byinshi, nuko nicyo kibazo turagifite. Ku buryo ibitabo ibiri gusohoka nyine harimo molecular findings, classification according to molecular findings, which we don't do in most of African countries. So we have add that. So now the type I have, but for type is a prototype hano, so ntabwo tabura uko yanditse muri WHO book. So itanga list ndende cyane ya types of the examples of the types. So I have chosen just the most common one. So astrocytoma, which means benign tumor arising from the astrocyte. Glioblastoma, it is a malignancy arising from astrocyte. Then oligodendroglioma, it is a tumor arising from the oligodendrocytes. And this can be benign or malignant, it depends on what histology finds. Pediatric diffuse low-grade glioma have diffuse astrocytoma is an imitation, so twebwe tuzibonye tugarukira diffuse astrocytoma because we don't do genetic testing here in our country. Pediatric diffuse high-grade now, so diffuse median glioma, these are imitation. Circumscribed astrocytic gliomas, here we have a pyrocytic again. Ganglioneuronal and neuronal tumors, and who has some ganglion cell tumor. So these two have free neurons ubwazo. So tumors arising from the ependymocytes have ependymomas. Embryonal tumors, you have medulloblastoma. You see a mutation here. Of course, we don't do it. Ariko is the medulloblastoma tubazibona hano mu Rwanda. Sashka. So meningothelial meningioma ni nyinshi hano mu Rwanda. So dufite no mu postgraduate turangije umwaka yakoze research project kuri meningioma, ariko yarebagamo cyane hari nyinshi zifite expression of progesterone receptors, kugira ngo tuzajye tuyipima ku bantu bose babonye meningioma, because it be from the cell lesion. So these are the main types I selected. So nk'uko twivuga rero, tumor nyinshi ku bana ziri muri infratentorial. So tentorial muri aka kari aha ngaha, ubundi niyo kurota bose ubona ko ari nk'igufa rikomeza kwinjiramo hano, ntabwo ari akamamurane gusa, ni nk'igufa rikomeza kwinjiramo ku buryo ibintu biri hejuru n'ibi hano hasi ubona ko bitandukanye rwose. In adults, most of tumors are supratentorial. So uko mubona utu tuntu turimo dutukura n'utw'umukara n'utw'ubururu, icyatsi kibisi, sorry. Icyatsi kibisi ni glial tumors, so arising from astrocytes. Others, the red are non-glial tumors. Noneho uko kaba kanini cyangwa gato, uko kaba kanini ukuba ni pourcentage y'izo tumor yanyu na tumors zose zo muri intracranial cavity. So you can see that meningioma, it is the most common one. Very kinini. Then gliomas of the cerebrum in adults, and glioma of the children in the cerebellum. So ku buryo bivuga ko mirongo ya tumors respiratory zira hejuru, naho 67% bya tumors mu bana zo muri intracranial ziba ziri infratentorial. So 2/3 supratentorial in adults, 2/3 infratentorial in children. Very simple to understand. So glioblastoma multiforme niyo navuga ya cancer. So high grade tumor arising from astrocytes. It is the most common primary malignant cancer in the central nervous system in adults, usually in the cerebral hemisphere. Usually it crosses the corpus callosum, ikakora hano, ikakora icyo bita butterfly lesion, so ikamera nk'akanyugunyugu kaya yafashe impande zombi. So characterized by lesions of necrosis surrounded by tumor cell pseudoparasitic. So here on the histology you see a necrosis here, and around it you have parasitization. So namaseli asana nayo bakafence cyangwa urugo around the necrosis. So there will be a proliferation of endothelial cells. So abamo vessel nyinshi cyane tuvuze twinshi, and the tumors are GFAP positive. GFAP ni protein glyofibrillar acid protein. So they have a poor prognosis. Nyango nabisobanuye n'aba bantu navuze ingero babiri kandi nta nugara abakera cyane biyamaze kwa president wa Amerika bose nyuma gato bagiye bapfa bishwe cancer. So nta muti n'umwe bamuhaye kuko nta wuhari. So meningiomas, which are the most common here in our setting, you can tumors zo mu bwonko bwe biragoye kuko ubwonko nyine bisaba ko ugenda ububaga. So nayo meningioma ibiri hejuru igihe ukuyeho skull bone uhita uyigeraho oyo ibira hejuru, keretse meningioma iramutse igiyemo munsi on the basal part of the brain, aho ngaho byaba ari ikibazo. So akenshi ni mu bagore kandi so birashoboka ko ariyo mpamvu biba ku buryo niyo umugore agafite agatwita kwa progesterone agiye hejuru gihita gikura kikabyimba vuba muri so. Nabo navuga ko umunyeshuri wacu warangije uyu mwaka ushize yakoze research tureba progesterone ndetse utazi on meningioma cases diagnosed research with Faisal and the Rwanda Military Hospital. So the patient will present with seizures. Seizures ni so it compresses the brain, but does not because it's not a cancer. But maybe these details we know them for those who do pathology. There are some which behave like a cancer, some meningioma. So I remember when I was in residency, quite a case someone was a meningioma arising from the dura, from the meninge, meninge kurikira gato optic nerve iza mu jisho. So agira tumor mu jisho rero abantu bakira ari tumor yijira ariko yari ya meninge. So but it was aggressive. It was aggressive because wabonaga ishwanya gusa na veins ikinjiramo iso. So I remember then when a conference in Cape Town, so my supervisor told me to bring that case there, the slides and the clinical information. How we should call it, because it was overtly like a cancer. So usually attached to the history showed the whole pattern as it is shown here. So schwannoma arises from Schwann cells. Mu gihe meningioma iza kuri periphery, schwannoma yo akenshi irimo hagati hahandi za cranial nerves zisohoke zishaka kujya aho zigana. Niba rigana kuri acoustic nizigana ku matwi, zigana ku hehe, aho zisohokera, aho izo nerve zasohokeye mu bwonko zitarasohoka muri intracranial cavity, aho niho zishobora zibazo. So frequently affects nerve 8, ngo nijya ku gutwi, cerebropontine angle, present loss of hearing, yes, nijya ku gutwi. So tumors will be S100 positive. So this is the marker we do in histochemistry. So if they are bilateral, it means this person is having a neurofibromatosis type 2. So oligodendroglioma, you can see it now here. Nubwo iri kuri meningioma, it compresses the brain, ariko it doesn't infiltrate. Hano wabwirwa n'iki ko yakoze infiltration cyangwa se yasunitse, urebera kuri iyi axis yo mo hagati. Ubona ko isa naho ikirambuye cyangwa se ikigorotse, no kuba kuri ako kantu ikasunitse ahubwo kinji it infiltrates. Iyo aba ari meningioma iba yasunitse, uyu murongo umanuka nawo ukaza hirya. So it is a malignant tumor of oligodendrocytes. It is a calcified tumor in the white matter, usually may present with stages. Fried egg appearance of cells on biopsy, or here on this histology diagram. So pyrocytic astrocytoma, it is a benign tumor of astrocytes, most common central nervous system in children. And kind of children, it will be in the cerebellum. Okay, so it's here. Imaging will reveal a cystic lesion with a neural nodule. So here, this is the, you can see ahari umukara cyane nuko ari site harimo amazi cyangwa se hari vito, one of them. But there is a solid nodule here, which is it is solid, it is fibrotic, and that's why it is whitish here. It is radio opaque, not radiolucent. So we continue with repeated this. So here we have rosental fibers. Wenda bireba muri histology. So tubonamo fibers nini zibyibushye zitukura nizo ziri kugaragara nashaka. So another type is medulloblastoma. Icyo nshaka kuvuga ngana kuri medulloblastoma, twanye kwifata abana kimwe na epandymoma. Epandymoma iva muri ependymocytes. So ishobora kuva muri fourth ventricle cyangwa se third ventricle and so on. Ariko fourth ventricle ko muri ziri hafi ya cerebellum. Medulloblastoma nayo iva muri cerebellum. So ikibazo rero kibaho nuko haje mutimera ari nini, ntabwo no kuri surgery bamenye ngo ese tumor iri kuva he. Iri kuva kuri ventricle ubwayo cyangwa se iri kuva muri cerebellum. So usually they don't know. So kuri histology natwe tugera ku so ikibazo nuko zivurwa muri completely different. So one is treated with radiotherapy, and another one is treated by chemotherapy. So treatments are quite different. Niyo mpamvu buri gihe uko byanda kose iyo tubonye epandymoma cyangwa medulloblastoma, we must exclude the other one confidently. So we do in histochemistry, which will show which is which. So medulloblastoma affects the children, epandymoma n'abana rimwe na rimwe ifata n'abakuru. But medulloblastoma is in the children and in the cerebellum, as it is shown here. So epandymoma I was explaining, also it affects the children, usually seen in children, although it can affect the adults. So in the fourth ventricle, also near the cerebellum, which makes it difficult to distinguish epandymoma from medulloblastoma. Uretse ko kuri histology hari bimwe na bimwe tubona ibi bya rosette zombi bizihuriyeho, ariko iyo tuyoboye icyo twita epandymoma rosette nibwo to confirm this epandymoma. Unfortunately, epandymoma rosettes are found in 1/3 of cases. This is not in all cases. So craniopharyngioma ngira ngo iri hafi ni n'ahandi hari pituitary adenoma. So ziri ahantu hamwe, niyo mpamvu mubona nongeyeho ya diagram kuyivura, gukora biopsy cyangwa gukora curettage, kuyishwanyaguza bakabisoramo banyura mu mazuru. Otherwise uko mubibona kugira ngo uzayivure uturutse hejuru bavuga ko uterura mu bwonko. which is not feasible. Okay, logical nako mu magambo byakorwa theoretical ariko practical is not possible. Ubwoko wabukura manga ugiye kuramo ikigema cyane. Niyo mpamvu bashatse uburyo bakanyura muri sphenoids then bakagera muri iyi cell region. Then you can here destroy and do curettage of pharyngioma or a pituitary adenoma as we saw last time. So this tumor arises from the remnants of last case pooch, present as supratentorial mass in a child or young adult, may compress the optic chiasma leading to temporal hemianopsia. Classifications are commonly seen on imaging, and niyo mpamvu isa akenshi ijambo izina ryayo rituruka kuri kuba isa n'amenyo. Kuri history isa na ameloblastoma, if you remember what we saw last time in head and neck tumor. It completely appears like an ameloblastoma. Kuri history nta kintu bitandukaniye uretse kumenya ngo iki cyavuye on this part, this one, this part, otherwise they look the same. So it is benign, but it recurs after resection. So that's all for these tumors. If you have questions, you can ask them. Do you have questions? So otherwise, I have 2 questions if you have time. If you don't have time, but you have 6 minutes left. So in the afternoon, we will not have lectures. I will just make an assignment. So you request to have assignments. So I will send an assignment to do. You can do it this afternoon. So otherwise, I don't intend to have lectures in the afternoon. So that's why I wanted that to finish this presentation before noon. So I have just 2 questions. Matching questions. Match the histologic feature of the left of the tumor on the right, or epidemiology, not only histology. It can be histology or just you match left to right items. I think ntabwo bikenewe kusoma anyone who followed can answer this quickly. Kugira ngo nubwo kandi mu kizami bigaragara ko hatsinzwe abantu batari bakenya ngo 10 na bangahe muri classes zombi. Most of the questions I gave they are actually coming from what I was presenting during the lectures. So meaning that hari abadakurikira cyangwa ari abasiba. So that is your problem. So to what I know, I try my best to explain everything, and also to giving these quizzes help. Just gives you an orientation on what you should know. So if you don't care about this one, so I don't know why then you should be in medicine. Okay, anyone to answer infratentorial epidemiology, infratentorial tumors epidemiology. So what is much with that?
I match with B.
With B.
Yeah.
Okay. Yes, that's true. 67% for intracranial tumors in children. So maybe we can go to B to 2 supratentorial tumors in epidemiology. Then so we BE. So in the adults. So hemangioblastoma.
Hey.
Hey.
Yeah.
Okay,
B.
perivascular pseudorosette is found in which one? So hemangioblastoma, it is sorry.
A.
Yes, perivascular
I
pseudorosettes.
A.
Okay, 4 goes with A, with a pandemomide, which is true. Perivascular pseudorosettes. While for 5, pseudoparasitic necrosis, microvascular proliferation, bizarre stages of mitotic vigors we found in which tumor?
D.
P. No.
D.
It is not. It is a C. It is these are features of glioblastoma multiforme. Nyango twari dufite n'ifoto ya histology yerekana necrosis around it. You have paristation. Aho navuze ngo bikora ikintu kimeze nka fences cyangwa urugo around the necrosis. Navugamo ko bikunda kuba vascularized, harimo endothelial cell proliferation and so on. So these are the features of glioblastoma. So hemangioblastoma, it is a tumor of cerebellum but in adults. And it is a kind of, it's an from meningitis. Nubwo yitwa gutya, so it's from meningitis. So question number 2. So which is an embryonal tumor? Which are the embryonal tumors here? Ngira ngo haguma muri ibintu bya general pathology. Kuko twaravuze general systemic pathology ni application of the principles of general pathology to specific organs.
I1 goes with E.
So embryonal tumor goes with E, which is true. Okay. So ngira ngo biroroshye twabibonye muri nomenclature of tumors. Iyo hajemo blastoma, this refers to embryonal tumors. Zose zirangizwa n'ijambo blastoma: neuroblastoma, retinoblastoma, nephroblastoma, neuroblastoma, medulloblastoma, and so on. So the tumor of the cranial and the paraspinal nerves. Which ones here? Kirango twanabivuzeho gato, nibura imwe muri zo twayivuzeho mu kanya.
B.
Yes, B. At least schwannoma yijemo and the neurofibroma. These tumors, they look almost the same. Zitandukana kutuntu dukeya. So meningeal tumors among these ones. Ukurikije ikibazo kirangiye nanabivuzeho gato. At least. Which are the hemangioblastoma? It is a meningeal tumor. So also hemangiopericytoma when it is arising in the intracranial cavity, of course. Otherwise, hemangiopericytoma ilionekana handy hengi. So tumor of the stellar region.
C.
Yeah, we saw there craniopharyngioma and the pituitary which we didn't see, but it is there also. You see that it is a tumor arising from the pituitary gland. So it is not a pituitary adenoma, they are different. So tumors of the pineal region.
Pineocytoma and pineoblastoma.
Okay, so I think this
D.
question was very easy. Okay, thank you. So we see each other next Monday.
Next weekend.
Next weekend too. So I will send the assignment. It's requested. Thank you.